started just a couple minutes. Good morning, everybody. Welcome to the Oregon Health Policy Board June meeting. I'm David Bangsberg, Dean of the OHSU PSU School of Public Health and Chair of the Oregon Health Policy Board. Great to have you all here. Decline that phone call from my mother. Great to have you all here. Just a few housekeeping notes before we start the meeting. First is please take a moment to, if you're a board member, have your first and last name displayed. And if you're a guest, we appreciate knowing who's here today. If it's comfortable, we welcome you to share your video as you participate in the meeting. And the Zoom feature today only allows meeting attendees to message the host and not other meeting participants. Any questions that you have or thoughts or comments should be mailed to the board at healthpolicyboard.info@state.or.us. Steph, will you do the roll call, please?
You got it. I was just updating it. Good morning, everyone. I'm going to go through alphabetically. So I'll begin with Oscar, which is an exciting surprise. Oscar Arana.
I think Oscar is away today.
I thought we saw his name.
We did, okay.
I guess not. David Bangsberg.
Here.
Ebony Clark.
Here.
Jessica Gomez.
Here.
Hello, welcome. Kirsten Isaacson.
Here.
Brenda Johnson.
Here.
Bill Kramer.
Here.
And John Santa.
Here.
Quite the full board.
Thank you, Steph. As regular attendees will notice, we have two new members of the Oregon Health Policy Board. We are thrilled to welcome both Jessica Gomez and Bill Kramer to the board. Great to have you here. Jessica, would you take a moment to introduce yourself to the board and to the people attending today?
Sure, thank you so much. It's a pleasure to be here. I'm Jessica Gomez. I'm a CEO and founder of a company called Rogue Valley Micro Devices. We make microchips down in Southern Oregon. So I live in Medford. I served on the healthcare cost growth target setting committee. It's a mouthful. And we did some really great work there. And I'm really happy to be able to join this board, excited to work with everyone and to get to know healthcare policy from this perspective. So thank you for having me.
Thank you, Jessica. Great to have you here. Bill?
Good morning. Thanks very much, David. I'm very pleased and I feel privileged to have the opportunity to participate as a member of the Oregon Health Policy Board. I'm currently Executive Director for Health Policy at the Purchaser Business Group on Health, which is a collection of large employers, some based with significant Oregon presence that are committed to improving quality and affordability of healthcare. Prior to that, I was an independent consultant. I'm based in Portland, and I had clients both in the public sector and private sector, among health plans, health providers, as well as Oregon state government. And then prior to that, I was with Kaiser Permanente in various places around the country, but the last part of my career, I was the CFO for Kaiser Permanente's Northwest region based in Portland. Again, I'm very pleased to rejoin some of my colleagues and help contribute to the work of improving quality, affordability, and equity of healthcare in Oregon.
Thank you, Bill. Well, it's great to have you both, Jessica and Bill. We look forward to working with you. I want to let the public know that we have one additional slot available on the Oregon Health Policy Board. Applications are accepted and are evaluated and accepted on a rolling basis in the governor's office. And information to how to apply for the Oregon Health Policy Board is available on the Oregon Health Policy Board's website. So if you're interested, we invite you to check that out and submit an application. So I think we're ready to move on to approve the minutes for May. I have a motion to approve.
This is Brenda, so moved.
Great, thank you. Do I have a second?
This is Ebony, I second.
All in favor? Aye.
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 Any opposed? Any abstain? Okay, the minutes are passed. Very good. Pat Allen had a last minute conflict, won't be able to join us today. So we won't have a director's updates, but we will have an update on several committees that have met over the last month where important work has been done. Brenda, would you lead with the update on the Healthcare Workforce Committee, please?
Sure, I'll be brief. The Healthcare Workforce Committee is deep in the thick of our listening session endeavors. They started late April, have gone through this month, the month of May, and will continue in June. There are about, I think, somewhere between 14, 16 different organizations that have been gracious enough to host our OHA and committee members for a very exploratory conversation around healthcare workforce needs, building off of things that we've heard from these groups in the past, asking probing questions about how we can inform that committee's work. And excuse me, and I think probably most notably, both the committee members, committee leadership, and staff have described how they've been really helpful in establishing new relationships or reestablishing relationships that perhaps haven't been as strengthened over time. So finding great value in those conversations. The second piece is just the committee is readying itself for potentially new behavioral health resource and funding, depending on how things move through the legislative session. And so we'll keep this board up to date on how they're contemplating what that'll mean for the committee's work. That's all I have for you for today.
Great. Thank you, Brenda. Any questions for Brenda? John, would you give us an update on the good work that Metrics and Scoring did this month at the May 21st meeting?
Sure. Thanks, David. Yeah, Metrics and Scoring had a long and productive discussion of the the kindergarten social emotional metric that OHPB discussed at our May meeting. All of the members of the committee expressed support for the metric. But there wasn't a vote to add it to the measures to be incented. That will come at the June and July meeting. So basically, Metrics and Scoring is in the final phase of identifying the metrics for 2022. Until the July meeting's over, what's in the package is still to be decided on. But it was a very productive meeting with a lot of submitted testimony and public testimony, and seems all positive. I think the other issue I would just mention from a performance measurement point of view is that OHA has been reporting on a very interesting project in which methods to measure equity have been applied to a subset of performance measures. And you know, the methodology is interesting, the results are interesting, and I think sometime it might be interesting for the board to hear the results of that, and just want to appreciate the effort OHA is making in terms of measurement issues related to equity.
Thank you, John. I had a pleasure to attend that meeting. Really was impressed by the group's good work, and think the kindergarten readiness measure is very innovative, and will help us all advance the governor's priority and focus on reducing health disparities and achieving health equity. So it was a real pleasure to be able to observe that meeting. I also attended the May 13th meeting of the Health Equity Committee, where we review the cost waiver. And we really had a robust discussion about the cost, Medicaid cost waiver, or Medicaid waiver, not cost waiver, sorry. Medicaid waiver really gives the Oregon Health Authority the permission to continue the foundational work to achieve health equity by 2030, according to the governor's priority, by the really revolutionary and policies that are implemented in CCO 2.0 to help achieve health equity, and especially the investments in social determinants of health to move upstream in partnership with the Community Advisory Committee of the local public health authority, to focus on behavioral health integration and a number of really important policies, as well as implement innovative measures like kindergarten readiness. And with that discussion, the Health Equity Committee had a unanimous vote to contribute in 3 ways to the Medicaid waiver. The first is to provide and review and provide feedback on the extensive community input that's already been received in order to guide the direction of the waiver. The second is to review the policies across the waiver to make sure there's a foundation that achieves health equity, and provide feedback to OHA regarding those policies. And the third is to provide general level of support as to how successful this waiver will be in achieving health equity. So I want to thank the Health Equity Committees for its great discussion and work and partnership in moving forward with the Medicaid waiver. Any questions for John regarding metrics and scoring or around Health Equity Committee discussions? Discussions, all right, great. We will next move to our legislative update. There's a big legislative deadline last week where bills not under consideration by the Rules Committee or Ways and Means were retired from the 2021 legislative agenda. Bill Shepard and Jeff Scrogan are here to share what OHA and OHA related bills are still active. Look forward to Jeff and Bill's presentation.
Thank you. Good morning. Thanks for having us. I'm Bill Shepard, Government Relations with Oregon Health Authority. Jeff, do you want to do your introduction? Kick us off?
Yeah, sure. Sorry about that, Belle. This is Jeff Scrogan. I'm with the Oregon Health Authority and Government Relations as well. Sorry for the delay. And before I get started, I'll kind of, I think, start us off. I want to welcome the new board members, I guess, and just say a little bit about who Bill and I are and what we're presenting on. Jessica, I think I knew from my Southern Oregon days. Hi, Jessica. And Bill, welcome to the policy board. Bill and I are both with the agency's government relations team. As you're probably familiar with, we're in the last month of our long legislative session, which occurs every 2 years. So one of the things we do is routinely update the board on legislation that the governor or authority are sponsoring and other related priority legislation. So this packet that was included in your materials includes OHA sponsored and governor sponsored legislation as well as other high priority health policy related legislation. I'm going to go through these slides relatively quickly. This meeting is part of a series during the session for the Board of Legislative Updates. And so previously we've talked and had folks come talk and specialize and focus on behavioral health or public health. Last session, if you'll remember, last month we had the Government Relations Director for the Health Authority provide a comprehensive overview of all the session priority bills. This time around, I think what we're going to do, I've asked if Bill's available to do, is kind of focus in on a couple key bills that I think would be of interest to the board, which have policy components related to things like Real D and data, as well as racism as a public health crisis and tribal matters. So I think that's kind of be our focus for this update, and to try and dive a little bit deeper versus have a broad swath. But you'll see on these slides kind of the broad swath, and then we'll kind of, as we walk through them, pause to focus on some key updates. Can we go to the next slide, please? You'll see the health equity definition that the board has voted to approve recently, reflected on this slide. Next slide. In the team, next slide. And this deadlines, Dr. Bangsberg mentioned a key deadline had recently passed for work sessions in the opposite chamber to be posted May 28th. And that's for, in layman's terms, for bills to be scheduled to be considered by those committees to move forward. If they kind of don't stay on a timeline to do that, the bills are no longer viable. Next slide, please. And this is just a quick count. This is a week or two old, but quick snapshot of where we were. Next. It's kind of how we bucketed the bills for this session. This is how the slideshow kind of organizes all of the bills, priority and non-priority, or priority and sponsored or non-sponsored. So reducing barriers to health and inequities in communities, reducing health inequities in the healthcare system, realizing better care, better health, and lower costs are triple aim. And then improving behavioral health services and decreasing behavioral health inequities. Next slide, please. Before I get into the bills on the slides, we're not going to deep dive most of these bills. You've all seen all of these bills before at this point. So feel free to, if you have a question on any of them, we're happy to try and answer the question or route the question. And then of course, our Oregon Legislative Information System, that website, has details on all of these bills as well. I am going to pause here and do the first two bullets on these slides and ask Belle to walk us through them. Belle?
Yeah, thanks, Jeff. Yeah, so the first one is expanding the traditional health worker categories to include a 6th category for tribal traditional health workers. So this has come from tribes through years of discussion. There is the House Bill 2088 that's currently in Ways and Means. It's related to the policy option package 404 and a pretty low fiscal impact. And again, something that's really supported by tribes and requested by tribes. So this, again, in Ways and Means, but looks like a positive move forward, not a lot of controversy there. The second one is a POP related to Indian managed care entities, also something that's come from our tribes and urban tribal leadership. This actually came out of discussions in CCO 2.0, requests from tribes to work with OHA to help build this managed care entity. So that has been a discussion that's been happening for the last 2+ years, and that is moving forward in conversations. There's been, I think, over 30 conversations with tribes related to this work, and there's further tribal consultation happening at the end of this week. So again, that is really great work, really to improve the health equity for tribes and make sure that they're recognized with some of their requests and their needs. I'm happy to answer questions on either of those two, or I'll just turn it back over to Jeff.
Thanks, Belle. Yeah, we can, go ahead, Oscar.
Belle, would that be for the 9 tribes? Maybe this is too into the weeds, but I'm just curious if that would be encompassing all of the 9 tribes, or is there only a few of the tribes involved?
Yeah, there's currently 4 tribes and the Urban Indian group that are moving forward with this. All 9 would be eligible, but 4 are really in the depth of the conversation, wanting to move forward. So, you know, future could see more tribes engaged in this as well.
Thank you.
Yeah, you're welcome.
Next slide, please. The other slide, actually, can you go back a slide? I'm sorry, I apologize. I wanted to, there's a legend on here that kind of helps you understand what the colors mean on each slide. So I don't mean to skip to the slide quickly, but want to point out that legend to you. That blue kind of means original OHA requested bills or governor's bills. Green just kind of shows you changes in real time. Sometimes concepts or ideas within concepts float around between bills, so you can kind of track those changes in the green. And then orange would be bills that aren't sponsored maybe by OHA or by the state, but are obviously high priority bills or bills that the agency is prioritizing for analysis in response to the legislature. Now we can go to the next slide. And you can see a whole bunch of these priority bills located on this slide. Next slide. I want to spend some time on this slide in particular. This is why I asked Belle to join us here. We have in this bucket of reducing health inequities in the healthcare system. You can see the first couple of bullets we have are related to Real D, sexual orientation, gender identity, and racism as a public health crisis. So we'll talk about some of the other bullets on this slide, but wanted to spend some time there and turn it back over to Belle.
Yeah, thanks, Jeff. So House Bill 3159 is also sitting in Ways and Means, and we expect movement on all the Ways and Means bills coming up pretty soon. But this one would be expanding Real D and SOGI data collection for insurers and providers to collect that on an annual basis. Work will also really happen internally at the agencies, both OHA and ODHS, in terms of shoring up and making more robust systems internally to collect these data and share with CCOs, so particularly through the one system data collection for those on Oregon Health Plan. As you may know, OHA and ODHS started collecting Real D data through different systems back in 2013, but there's a lot of resources that need to be allocated to increase those efforts, not just internally, but externally. There was also additional movement on Real D data collection for COVID specific encounters, working with hospitals and FQHCs, et cetera. And so that work has been happening and things have been moving forward on Real D data collection, but we've also had requests from advocates around sexual orientation and gender identity data, which some agencies already capture, but it's not been a robust process. So again, that bill will be, is in Ways and Means. It will require significant resources because there is updated systems that need to occur and staffing for training, education, and support of providers and insurers, but has had full support of advocates and provider partners. I can pause if anyone has questions specific to that bill. I could go deep in the weeds, but I'll leave it where it is for. Okay, and then racism as a public health crisis comes from Oregon Public Health Association Health Equity Task Force and is sponsored by Representative Salinas. There's been a lot of work on this one specifically. The group sponsoring it really wanted not just to have racism be declared as a public health crisis, but to do something about it. So we've seen a lot of efforts nationally and even locally in Oregon to declare racism as a public health crisis, but there's not always teeth behind that or work behind that to prove that that's moving forward. So there are lots of efforts and ideas related to this bill originally. It just passed out of rules last week and has moved into Ways and Means with three kind of distinct areas of focus. One is looking at Real D data collection across state agencies. So there is a proposed assessment to do that. So as House Bill 3159 will capture probably a majority of Real D data as that passes, there would still be some gaps in Real D data collection. And so looking at assessing what could be good data systems to continue to collect that. So we see Real D data for 100% of Oregonians. So that's one area of focus. Second area of focus is on mobile health units. So there is both an assessment of mobile health units and a proposed pilot of mobile health units that would fund 1 to 2 mobile health units across the state. So OHA would be setting up a program around mobile health units, how to fund that, and set up an RFP process, and simultaneously assess mobile health units and how those work to reduce health inequities in the different programs that run those. And there, as we know, are several already across Oregon, but how to increase and improve that. And then that assessment would come back to the legislature with proposals and ideas on potentially expanding those mobile health units throughout Oregon. And then the third area is around affinity task force groups. So creating groups that really focus in on specific populations, communities of color, to identify the best ways to reduce racism and reduce health inequities. So that bill has moved forward with those 3 specific focus areas. There, like I said, there were several more in the original bill that may have landed in other bills. I'm happy to answer questions about that as well.
So I thank you for presenting that. And so in that third topic area that you spoke to in terms of affinity, work groups to kind of hone in on specific communities, do you know if there's also a recommendation around bringing forward a level of funding or resource, because as a group comes together to identify a need and a strategy, if there's no dollars or resource that can support kind of the recommendations, it's hard to then, move forward. So, and again, this is a very in the weeds question statement, but do you know if there's any kind of acknowledgement or elements of that also as this is being fleshed out?
Yeah, thank you for that question. Yeah, so I think the intent is exactly that, to bring recommendations and ideas back to the next legislative session to identify ways to continue to resource these different efforts. Absolutely. I think that's an important piece. And again, the intent of the bill as a whole is to make sure it's not just about talking about the issue, but resourcing this on an ongoing sustainable basis. So thank you for that question. Any other questions, or I can turn it back to Jeff? Okay, thanks.
Thanks, Belle. And we'll, of course, be back to update the board on both of these. I think that this touches 2 different areas the board has had conversation about before, which is better data systems related to REAL-D and implementing REAL-D across the state, and racism as a public health crisis. So as these bills move forward in the legislative process, we'll keep you updated. We should have a substantive update at your next board meeting when the legislative session is adjourned. So we'll know what shape these are in pretty conclusively by that point. I was going to spend some time on some of the bullets on this slide. As a health policy person, most of these bullets are extremely exciting, if not all of them, but I think I'll fly a little close to the sun here and we'll see how my wings do. Can you go forward a slide and one more slide, and we may go back as needed. So I just wanted to have a quick update on the behavioral health work that's going on. And like I said, I'm going to fly a little bit close to the sun here, which is to say I don't have a whole bunch of knowledge that I can share with the group about something that I'm going to give an update on. I think the legislature is considering a very sizable investment in behavioral health services this session. And it may be in healthcare the largest single investment that new investment that they're going to make, certainly not the largest investment. With that kind of new investment, if they proceed as the current chatter and discussion seems to be lining out, I think that there could be a lot of direct work, indirect work for the health system to respond, which could include the policy board. And specifically, I think that there could be there's a conversation about, what does accountability look like in the behavioral health space if the legislature is going to make this type of investment, and how does that accountability mesh and match with the other health system transformation accountability programs we have. So I don't have a lot of detail to give the answer to that question. I think that we want to make sure that It's coordinated and aligned with the other systems we have so that we don't stand up something in a silo. But other than that, I think I just wanted to maybe flag for this body that I think that the legislature is considering fairly sizable investment in behavioral health. And that may mean that at the end of the session, there's a surprise or two about what that investment looks like or what the system has to do to respond to that investment, both to push dollars out the door right away and see those improved services, and or as it relates to like reporting and accountability and transparency.
So Jeff, behavioral health is my world. So, I'm going to say something really quick. So this is super exciting. And I understand that, you don't have a lot of, answers to bring forward. But, I do just want to say that from my perspective too, super appreciative and excited and looking forward to kind of how this plays out. And I also want to highlight that, we have a full continuum. And I feel like a lot of these are really focused on kind of crisis and some more of our short-term needs. And so I think, it's important also, and what, I'll be kind of, looking for and recommending is, how do we sustain in terms of kind of some of the long-term needs. And so when someone's out of crisis, then what's that next step, and how are we also working on focusing and expanding that continuum? You talked about coordination in terms of accountability. That's a very, very, very important. And so I look forward to some intentionality around looking at how do we have continuity kind of across metrics from, the work specific to CCOs or CMHPs and OHA. And then the last question I did have, and I don't know if you can speak to this, but I'm interested in hearing a little bit more detail on specifically how does these investments or this investment also impact OHA as an agency? And so I don't know if you're able to answer that today or not.
I'm able to say it will have an impact on the agency, a significant one. I think some of it really does depend on how the negotiations play out right now in real time and what the specific legislative direction is to the agency as it relates to these investments. So I think the other comment you made about maybe aligning is just completely right on. And I think people are really taking a look at how we don't create a siloed structure now and ensure that it's aligned with both a long-term vision, maybe to your point, Ebony, about like how do we ensure continuity of systems and of care, and short-term vision to use some of that money right away to improve services. So I think there's a few conversations going on, and how do we shore up infrastructure now? How do we ensure accountability? And how do we work on that workforce pipeline piece? So I say all that to say, in an hour, the conversation is going to change and there'll be 3 other buckets. So.
Yeah, no, I appreciate that. And I'll just say that I'm just going to keep asking the same question. So awesome. And thank you.
Keep asking, thanks. And we will have to keep being prepared for what the role looks like for the agency. And my flag for you, the board, is there may be a role for the board as well.
Jeff, I think Bill has a question.
Yes.
Thanks, Jeff, for this presentation. And my question builds on Ebony's questions and comments. I was struck by your use of the term silos, and my impression, not knowing all the details of these bills, my impression that these are kind of targeted, kind of crisis-oriented. Question as a new board member, to what extent do we as the board and Oregon Health Authority feel that behavioral health services need to be integrated with primary care and comprehensive care in the state versus a kind of standalone behavioral health services? So it's a kind of a broader question than just legislation, but obviously that kind of response to that question would help guide what kind of legislation would make sense in terms of being integrated versus standalone services.
Well, at the risk of speaking for the state, I'll say integrated is the preference. I think that we've seen that in legislation in years past and in public presentations from both the legislative bodies and even this body. So I think it's okay to say integrated is the goal. And then what I heard, Mr. Kramer, that kind of I wanted to flag for the group is, especially as it relates to being a new board member, I think the board has done a lot of visioning around what this next year is going to look like, and we'll receive some correspondence from the governor's office and priorities and kind of tried to map out what is our work going to be for the next year. And I think that's great. And I really don't know how much this stuff is going to add to that plate. And that's kind of what I want to flag for both, to Ebony's point, the agency, and to your point, maybe the board itself. I'm not sure what it will look like and how that sausage will turn out at the end of the day.
And Bill, let me also address your question. When the governor set the priorities for CCO 2.0, she set several priorities: health equity, cost containment, social investment, social determinants of health, and the fourth one was behavioral health integration, to move behavioral health services into primary care. And I think we developed a CCO 2.0 policy framework with a real emphasis on that.
That's great. I recall seeing that too, and I think that is makes sense. Now, it's hard to do, and it's hard, particularly in putting together individual pieces of legislation that may or may not support that. But I think that makes a lot of sense. Thanks for the clarification. I really appreciate it.
And I think that COVID-19 certainly kept us busy, and will be really important for us to go back to see how successful the CCOs have been in implementing that.
The last thing I'll say, I'm so sorry to piggyback on kind of what Bill highlighted, and y'all have heard me say this before, and I just want to say it one more time, is that when we think about, the publicly funded behavioral health system, it's not just CCOs, it's not just the counties, it's not just the state, but it's all three kind of major entities playing and bringing forward their piece of the puzzle. And I'll just say that I'm a believer that, there's a role for each, so if we shift only to, let's say, CCOs, I say that, local mental health authorities and CMHPs play a critical role in the success. And so there has to be that partnership and collaboration across kind of the pillars of our continuum.
Well said. Thank you, Ebony.
Thanks, Dr. Bangsberg. Thanks, Ebony. I was gonna, talk about providers too, but you nailed it at the end of your comment. So I think that's totally right. Something we're keeping in mind is where providers within that kind of county, state, CCO mix. Okay, I'm gonna try and get away with this with my wings attached and go back a slide or two and wind up by talking about some of the stuff on that slide. Can we go back one more? Just one more. I think, this one. So just wanted to kind of talk a little bit about some of the components on this slide, as well as I think some of these components have been of interest in the board previously. Kind of going through this list here, there's a cover all people concept. Two versions of the concept are currently alive: House Bill 2164 in the Rules Committee, and then House Bill 3352 is alive in Ways and Means. 3352 would be a broader and more comprehensive coverage expansion to folks who would be eligible for Medicaid, except for immigration status. 2164 is costs less, and that's because it's crafted around specific populations within that bucket rather than the entire population. Both of those bills are awaiting further action. Senate Bill 70 expands and puts in statute the definition of regional health equity coalitions. Regional health equity coalitions are on the ground, in the field, experts with experience regarding health equity and help improve both the authorities, policy development framework and processes, as well as local healthcare policy development processes and frameworks. The next bill on our list here is around healthcare interpretation. Representative Salinas has House Bill 2359, which represents more accountability into the system for using qualified and certified healthcare interpreters. The next bullet on here has to deal with a policy option package, which really right sizes the agency's equity efforts within our Office of Equity and Implementation to make sure that the infrastructure within the agency is set up to match the agency's 10-year priority and this board's guidance around the definition of health equity and prioritizing that work. The next bill on the list is House Bill 2081, the cost growth target bill. I know you're going to get an update later today on the cost growth target work, and the only update I can see around this bill is the bill has passed and is awaiting the governor's signature. So many of the bills at this point in the legislative session, which do not have financial impacts directly to the state, have been considered or are being considered on the floors of the respective chambers. This is a good example of one that's made its way through the process. The next bullet was regarding value-based payments and was carried within the House Bill 2082 concept, and that concept has not moved forward as part of the voluntary compact signed as recommended by the implementation committee of the healthcare cost growth target program. Next bill talks about pharmacy costs and using the state's levers to reduce pharmacy costs, as well as addressing some administrative issues. The agency's bill, House Bill 2080, is not moving, but Senate Bill 848, sponsored by Senator Patterson, Representative Prusak, and Representative Nose, is alive and in Ways and Means and contains most of the policy components that were originally considered within House Bill 2080. So in Ways and Means and considering action. Then you see some orange ones here, which are to show that these aren't, necessarily filed by the agency, but maybe are a high priority for the agency. What's known as the HOPE Amendment, which was referred by the legislature to the people for considering access to healthcare as a constitutional right. Work to consider further development of a public option in Oregon, House Bill 2010, is in Ways and Means for further consideration. This would kind of keep building on Oregon's research and reporting structure for how to do a public option, but move us closer by specifying more specifics around what's needed for implementation. What are statutory changes? What are methodologies? Let's move from hypothetical reports into implementation planning through those reports. And then Belle, do you want to talk about Compact of Free Association Dental, Senate Bill 557 to end us?
Sure, just real quick. You may or may not know that COFA had the COFA populations of Federated States of Micronesia, Palau, and Republic of Marshall Islands were reinstated Medicaid benefits at the end of 2020. Those benefits had been given to those populations after repeated bombings of those communities and other health effect issues that were created by the United States government. But the Medicaid establishment was actually taken away about 25 years ago. And so there's been work to reestablish that for many, many years. And so this dental program actually, or this bill started before that was reinstated, but this will help fill the gaps. So the majority of folks will be eligible for Medicaid or some type of Medicare, but it can fill the gaps. This bill will fill the gaps on those that might not have dental coverage through Medicare. So it's a smaller population than was originally identified, and it's great news that Medicaid is reestablished, but still want to assure that these population who really did have significant medical effects based on U.S. Bombings essentially can have some services, and so that's the piece that's related to that. And there's an additional COFA bill 706, I believe, that would support outreach to assure the populations are aware of their Medicaid coverage and can get access to that too, because populations have not had that for 25 years, so may not be aware of really what that benefit is.
Can I ask a question?
Yes.
So this is interesting. So this seems like the United States is trying to respond to a historical injustice. And in doing so, they're giving Medicaid and Medicare benefits. Is that correct?
Again, yeah, so thank you for the question. Yeah, so this was in the original agreements that were established in the 60s that folks would have access to medical benefits. And of course, as is true in all medical benefits across the states, there have been different pieces that work differently. In fact, Oregon has been supporting medical benefits through the marketplace for this population for quite a number of years. But now the federal government has stepped up and said we will reinstate these benefits that were originally agreed upon in the 1960s and 70s. And just like you're saying, to establish that historical issue.
It just seems like an interesting policy precedent.
Bill, and if I see Jessica has her hand raised.
Yeah, Jessica.
Hi, thank you. Yeah, I agree. That's interesting take on policy. My question is around the public option and how are we looking at value-based payment system as part of the public option, or because I mean there's the cost component of that and then you have sort of the coverage component. Is that part of the conversation, or are we kind of pushing off the value-based payment conversation to later? Do you know where we're at with that?
This one's for me, Jessica. That's a great question, and a great question from a board member. Perfect. Yeah, the bill actually does contain value-based payments explicitly as something to look at, both in like the whereas section of the bill, and then specifically within the charge of the bill, value-based payment is called out. I think we are trying to leverage some of the tools we're standing up or have in place while we're doing some of the policy design for some of the other stuff. So, you know, one of the things required in the plan by the bill is how the state can further health system transformation goals through the use of value-based payments and global budgets when implementing a public option. So yes, explicitly in there.
Thank you so much, Jeff. It's great to see you, by the way.
Good to see you too. I also need to clarify, I got a quick communication. House Bill 2081 has definitely already been signed by the governor. So I was correct that it had passed both floors, but has also been signed into law.
Jeff, I have a question. In the waiver materials that we are going to be talking about later, there's a lot of conversations about the health equity coalitions and also look at health equity innovation as well and health equity innovation zones. So with Senate Bill 70 and then the health equity innovation and implementation policy option, how are those aligning with, you know, sort of the waiver, the next waiver? And are they aligning?
They sound aligned to me, although I'm going to defer to Jeremy on this question. Don't worry. I will say, as it relates to the bills, I think one of the things they help do, specifically the two you mentioned, the two bullets on our slide here, is stand up the infrastructure to move forward that kind of policy. Like we have a few regional health equity coalitions, I think, but they're not statewide and there's not a statutory definition for them. Same thing with like the internal agency structure as it relates to how we support that work at a staff perspective within the divisions. I think these are both kind of infrastructural pieces to help develop more sophisticated policy, but I turn to Jeremy as it relates to alignment with the waiver development process.
Nope, I totally agree with you, Jeff.
Great. I do have one more bill to share with the board, but I can pause and do questions now or do that one. It's up to you, Chair Banks.
Keep on going, Jeff, and we'll wrap up with questions. We're doing well on time.
Great. Next slide, please. And I'm sorry for skipping around on these slides. Thanks for your patience. So I just wanted to point out at least one bullet on this slide, which is the very first bullet, leveraging the purchasing power of the marketplace, Senate Bill 65. Senate Bill 65 is in Ways and Means Committee. And we've brought this to the board's attention before, but just wanted to make sure as we get kind of closer to session, it pops back up on radar. I think the idea here is that the marketplace, which is housed in the Department of Consumer and Business Services, DCBS, would kind of drag and drop over to the agency. So the agency would be running the Oregon Health Insurance Marketplace, where folks go to get their individual health insurance through the ACA, through the web. And we're not planning any changes as a result of that drag and drop. It's not like we're going to get it and then do X. I think that the plan is to get it and make sure it functions as it currently functions now to the degree we can. But I think it does do exactly what the bullet says, which give the agency flexibility to leverage the purchasing power in the future. So just wanted to make sure that bullet was still on folks' radar as that bill is still moving forward in the process. And I think that's going to wrap up my call out of specific bills unless there are questions about any.
Jeff, I saw your next one was operate fee for service as a CCO. Curious as to how that works.
Yeah, I think that POP remains in question. And the basic idea here is, coordinated care has become the gold standard for care service delivery in the state. The coordinated care model that the board helped inform through 2.0 really does deliver great quality care. So the question is, and this POP is intended to help move the state more towards using that fidelity model in the fee-for-service area, in the open card area for Oregon Health Plan.
Thank you. Any other questions from the board, either Bill or Jeff? Well, thank you both for a great review of a busy legislative session. We look forward to seeing this all get wrapped up in the very near future.
Thanks, Chair. And if you all have any questions as session closes out in the final month, don't hesitate to write the GR team. Anybody on the GR team will make sure it gets to where it needs to go. And we'll look forward to giving you an update next month. Thanks again.
Thank you.
Well on time. Our next topic for discussion is cost growth target program, where we have Jeremy Van de Hey and Sarah Bartleman here to give us an update on the progress of cost growth target.
Thanks, Chair. I'm going to turn most of this over to Sarah, actually. I'll just say a couple comments. I know there's a couple slides of this, Sarah, but so I don't bounce around, I'm just going to do this in opening and let you cruise the slides. First, Bill and Jessica, really excited to have both of you join the board. I think your experience on this topic is going to be hugely valuable. As we're really excited, we move into the next phase of implementation here. Two major milestones over the last month. First, passage, as Jeff talked about, passage of House Bill 2081, which is the accountability measure for the cost growth target. This is the strongest accountability that any state has adopted for accountability. There's, as we talked about, there's several states launching these programs. We're only the second state with legislation initially, but there's about 5 states that have launched these now, and we should say we're the 5th, and then 3 or 4 others that are in the process of launching it, but no other state has adopted a strong accountability. So I think that's something to be proud of, to have the tools to not just measure and report out, but to have accountability within the system as well. The second piece is the value-based payment compact, and we've talked a little bit about this before, but just a reminder that last month we announced that we've had about 45 organizations across payers and providers and state payers, state organizations as well, sign on to the compact. On the payer side, that represents 71% of the entire population of the state, which is pretty remarkable because there's a big chunk of the population that's a Medicare that we would never be able to really get to sign on. So it's really the bulk of the rest of the market that is signed on and committed to advancing value-based payment over the next several years. We'll be there's a new work group that's being stood up that we're hosting in partnership with the Oregon Health Leadership Council that will really help with implementing and be a forum, sort of a centralized forum for addressing challenges as they pop up as we're moving through value-based payment. Just to give you an example of types of things we expect to pop up is there will, I think, be conversations around if we're going to pay providers for value, then folks really need to be tied to a primary care provider. And so what do you do in those insurance markets where folks don't have a primary, or right now are not currently assigned to primary care providers? It's really not a Medicaid issue or Medicare issue or commercial issue. It's how do we, collectively move to value-based payment. So this work group will be a forum where we can bring those types of issues forward and try to problem solve across the industry and across payers and providers. So that's really exciting. And I think just like the accountability piece, we've not seen any other state that stakeholders have come together and made this large of a commitment to value-based payment. So I'm excited to get both of those off the ground, and we'll turn it over to Sarah.
Thanks, Jeremy. Next slide, please. We are going to fill in a couple more implementation updates for you since it's been a few months since we've talked. Jeremy's already shared a couple. I have a few more to add. We're then going to share a couple of updates from our last cost growth target implementation committee. One is related to identifying and prioritizing strategies to mitigate cost growth, and how that process and those criteria and that whole cycle of identification and prioritization intersect with you as the board. And then finally, we're going to share some data from the Oregon Health Insurance Survey related to consumer cost impact. This is data that we shared with the implementation committee at their last meeting, and we thought it would be helpful to make sure you all had that just for some additional context as well. We've definitely used some of these talking points with you before, but this is a little bit more detailed and built out for you. So let's go ahead to slide 5, please. One more. Thank you. Okay, so one of the big focuses of our implementation work this year is developing the first data submission. So our first data submission will include essentially baseline data from calendar year 2018, 19, and 20, and it will be due in October. So we've been working with our new technical advisory committee. We've had a number of meetings already and have really been working on all the details that need to go into that data submission template and specifications. All of the data submitters who have data due on October 1st this year were notified last week. We have 2 more technical advisory group meetings that we're fitting in before the end of June. Temporary rules are being filed. We'll be releasing the specifications and template at the end of June, and then doing training and technical assistance for data submitters throughout the summer leading up to that October 1st date. So really excited to be getting a little bit closer to having the first, having that first baseline data come in. Next slide, please. One of the other focuses of some of our implementation work this year has been building out our framework for monitoring. And so this is our quality and equity work stream, where we've been focusing on how do we measure and report on additional things, not just cost growth and cost growth trends, but also understanding what's happening with quality, access, and other considerations to make sure that we're not having any negative impacts as payers and providers are working to contain costs to meet the target. So one of those recommendations that came out of the implementation committee that you've talked about before is to have a standard set of quality measures, or a subset that we would report on annually when we report on cost growth target performance. This is really focused on measures of, again, standard access and quality, sort of broad utilization measures, maybe some preventive care measures. It's not the full breadth of everything that we want to be measuring and looking at negative impacts on. This is just the first slice of that work. Remember, we had talked before about the 3 different strategies in this group. So this is part 1. We've been working with the Health Plan Quality Metrics Committee over the last couple months, and at their meeting on May 25th, they approved and adopted this subset of measures for us. So as you can see on the slide, it's a short list of measures. Most apply to Medicaid, commercial, and Medicare, although there is a little bit of nuance for the child and young adult focused measures. So we've got some well child visits, we've got colorectal cancer screening and statin therapy for patients with specific chronic conditions, and then we have some broad utilization measures. So emergency department utilization, mental health treatment, population reach, initiation and engagement of alcohol and other drug dependence, and then hospital all-cause readmissions. So again, we're going to be working with the metrics team and with our all payer claims data team to figure out what the right plan is for producing these measures. These are things that OHA will be reporting on and making part of our public reporting. These are not intended to become, the new set of incentive measures. They're not being built into contract anywhere. They are just for reporting to accompany cost growth target performance reporting. I'm going to stop there for a second and see, Dr. Santa, do you have any reflections from the Health Plan Quality Metrics Committee conversation on May 25th that you'd like to add?
Yeah, sure. Well, first, I think Sarah did just a terrific job of working with the HP QMC and moving through this and differentiating it from their previous work, which, it's a different sort of thing. And I think, you see a broad, reasonably broad, doable set of measures to start with. I personally think that the most important stuff may be found by in a good database by smart analysts, and the way Sarah has pursued this suggests to me that the process is resulting in both of those elements. And so I was impressed with this work.
Thanks, John. Let me go to the next slide and share a little bit more about the second part of the framework for monitoring. So looking at the negative impacts of the cost growth target and some of those additional considerations beyond maybe the standard quality and access measures, which we know also have a connection to negative impacts. So this is conversation that we are having with the Health Equity Committee. We had a discussion with them back in April and presented the overall framework and some of these ideas and how we were thinking about the conversation. And one of the points that they made back to us very strongly that I wanted to share with you all was we were originally framing this conversation as wanting to make sure that the cost growth target and work and efforts to meet the cost growth target did no harm. We were really focusing on, we want to think about where there might be harm in the system, what should we be measuring, how can we avoid those negative impacts? And the Health Equity Committee really encouraged us that do no harm frame is a neutral place on this spectrum that you see on this slide, and that they encouraged us to really think beyond this neutral space and to think more proactive. Where are some opportunities where the cost growth target program and these levers can actually drive proactive improvement in the healthcare system and not just looking to avoid harm. So we are regrouping a little bit and thinking about how this feedback affects how we were originally framing this conversation, what this means for the framework for monitoring, and we plan on picking this conversation back up with the Health Equity Committee in July. So no news to report in terms of what we might be measuring in this framework yet or where this is going, but thought that this was really important feedback for the Health Equity Committee to share with us, and it's helping us ground a little bit better. Dr. Bangsberg, do you have any additional comments or perspective on the April Health Equity Committee meeting?
No, I think they were very well aligned with this and very deeply engaged. Thank you.
Great, thanks.
Can I just add, sorry, and I know this is probably not the best time for a question, but I almost would, where it says proactive improvement, in parentheses, do undo harm. But anyways, I'm just thinking out loud.
Thank you, that's great feedback. Are there other questions or comments about any of the updates Jeremy and I have shared so far? Okay, let's jump then to the second part of this update, identifying and prioritizing strategies to mitigate cost growth. Go ahead, 2 more slides, please. Thanks. Okay, so let me introduce you to this graphic, which we are now starting to use more broadly in our cost growth target program, and what some of the other states with cost growth target programs are using. And this really is meant to represent the sort of annual cycle and the process that we will go through with this program. So starting at the top right at about 1 o'clock, we have measure in that yellow box or yellow circle. So that is the foundation of this program. We're starting by measuring performance relative to the cost growth target. The cost growth target's been set, the methodology for that measurement has been set, and every year we'll be collecting the data and comparing performance to the cost growth target. We'll then move clockwise into analyzing. So we'll be analyzing the spending and the trends to understand what is driving cost growth. What are the key factors? We know that there are some big things that are pretty standard. They're pretty consistent across the country, but we know from the states that are a little bit ahead of us in this work that there really can be some variation under the surface. So in a commercial market, the big spending drivers in one year might be really different than in the Medicare market. We've seen some of this. Rhode Island just released their first report, and there's some really interesting nuance under the surface. So really understanding and analyzing the data to know what's happening. That will lead into reporting out. So public performance against the cost growth target. What are those cost growth drivers? We're working internally and with other states on a recommended set of standard reports that will help understand all of that analysis. This is also where we will plug in that framework for monitoring work in the public reporting. And then the whole point, well, one of the points of this, reporting is a huge strategy, and transparency is really key in and of itself. But part of the goals of that transparency is to then identify opportunities and strategies to address that cost growth or to address those drivers that we see. So we really want to move into identifying those strategies, what are the opportunities? What can be done about this? What are some additional policies we need? Is it legislative? Is it programmatic? Is it agency? What are the things that we could be doing? What should we be doing? And then moving that into implementation. And then to complete the cycle, is it working? So then we go back into measuring and we come through the whole process again. So pretty straightforward from a process cycle, maybe oversimplified. This is not necessarily linear, but I'm trying to make it that way. But where we really want to focus today, next slide, please, is in this space between identifying and implementing. So how do we decide which strategies are the most worthy or should be prioritized? We know that we, the state, we, the board, we payers and providers, we all have a limited capacity and resources to make all of the changes. And so how do we decide which ones should be focused on and which ones are the most likely to have an impact in addressing cost growth and the cost growth drivers that we've been able to identify? So the implementation committee and the policy board have already prioritized value-based payment. We can think about that as our first strategy that was prioritized and advanced forward with the value-based payment compact and the compact work group and all of the implementation work that will be happening this year and beyond. But as we're reviewing data and going through this cycle of measuring, analyzing, and reporting, we anticipate lots of potential strategies being identified. And so just an example from Rhode Island, which again is about 1.5 years ahead of us in this cycle. Next slide, please. They have gone through this, and really, as they started looking at data, they realized that they were having ideas coming up, and how do they decide what to prioritize? Because again, more ideas came up than they had bandwidth to take on. So they developed criteria to assist in strategy prioritization for cost growth mitigation. They found that a large percent of their increase in medical spending was being driven by pharmacy prices. They've decided that taking action on retail pharmacy prices met their criteria, and that's led to a tri-state strategy adoption. So Connecticut, Massachusetts, and Rhode Island are working together now on a similar policy that will cap the cost of prescription drugs in these states. So this all, I'm again oversimplifying the process that they went through, but they did develop some criteria for strategy prioritization, and they've already made progress in doing that. And so our implementation committee thought that it made sense to look at a similar process and criteria to guide these decisions in our state. Next slide, please. So at the committee meeting last week, they adopted a process and criteria to guide these decisions. So we wanted to share that process and criteria with you and think about what that means for committee and board interaction and what this might mean for board policy, agenda setting, and board engagement in some of these strategies as well. So to go a little bit deeper into each of these three steps in this process, next slide. We envision that there are a number of ways that potential strategies could come up, and we broadly categorize them into two options. So the first is being driven by that data analysis through that measurement, analysis, and reporting cycle. So there will be opportunities where we will very clearly see, oh, X is driving spending, or this seems to be a real problem for Medicaid, or this seems to be a real problem in the commercial market, and that will identify opportunities for improvement. The second bucket, and probably where I see a big role for the policy board, is just conversation with stakeholders, with committees, with other experts, identifying strategy proposals based on other considerations. So things that you are hearing or experiencing as you touch the health system, as your constituents, or as your own personal experiences are identifying. And those things will come up consistently. Some of that might be sparked by the data analysis and the reports. Some of it might be sparked by experiences that you're having or conversations you're having. But there are all kinds of places where all of that can plug in and strategies could be identified. So what we're proposing, and what the implementation committee has adopted, is that those strategies would be identified on sort of a rolling basis, and as strategies come in, they would be assessed against a short list of criteria. Next slide. So there are 4 criteria for assessing strategies that have been adopted. These are a little wordy, sorry about that. Let me talk you through them. So the first criterion is that analysis of the spending data indicates a significant opportunity for reduced spending or spending growth. So there's been a lot of work recently that there might be Is there really one single thing that is going to impact the health system enough that will address healthcare cost growth broadly? Is there a 5%, is there a 10% cost growth driver that we can just pinpoint and say, yes, if we fix this, it'll bring costs under control? Probably not. There's been some really great work with a team out of Yale about 1% strategies, and that we might need a whole broad suite of little things that add up and cumulatively will have an impact. But we also want to make sure that we're not essentially playing whack-a-mole or chasing a bunch of strategies that might really not have significant impact. And what significant impact means or significant opportunity, we can debate a little bit more, but essentially we want to make sure that what we're doing has the possibility to have a meaningful impact, and that successfully addressing that opportunity would have an impact on cost growth target attainment. So again, if we put all of these efforts and we direct a lot of attention across the state, payers and providers into working on something, but it really isn't going to help us meet the cost growth target overall, is that really where we want to be going? The third criterion is that published evidence supports the strategy, or if not published evidence, because we know sometimes this can be sort of that cutting edge, bleeding edge, there's at least a compelling logic model or a compelling argument that supports the strategy. We think that if we do X, Y will happen, and Y will help us meet our cost growth target goals. And then fourth, that there's capability and capacity to effectively implement the strategy in a timely manner. And that resources required to do that would not detract from previously prioritized strategy design and implementation. And this is something that the implementation committee spent quite a bit of time talking about, because we have already prioritized value-based payment. We want to make sure that we're not taking away effort from that, and that those payers, providers, other stakeholders that are working to implement these strategies have capacity to do so successfully, and not essentially concerns about being stretched too thin, whether that's at the agency level or the payer, provider, stakeholder level. Let me stop there for just a second. Jessica, is there anything that you'd like to add from the committee discussion that we had on these criteria?
No, I think you covered it very well. Thank you for that.
Okay, thanks. Okay, so we can talk more about the criteria in a second, but let's go to the next slide and talk about how strategies will be assessed against the criteria. So the process that we have approved and the committee has adopted is that the implementation committee chair, vice chair, and the OHA staff would score any suggested strategy against those criteria, those 4 criteria, using a 1 to 3 scale. So met, did not meet, but that each criteria would be assessed independently. So we don't want to add them all up together. We think that implies maybe a more official rubric than this really is. We wanted this to be sort of a loose approach, but that the thoughts from that scoring would then be presented to the committee for discussion, and that the committee would then consider whether or not to recommend pursuing the strategy. And we think there are a couple of different options for how that conversation could go. The committee could recommend proceeding with the strategy. They could recommend or request additional research. Maybe we weren't able to score something, or we didn't have enough information to adequately really answer one of the criteria. It could be that the strategy needs modification, maybe modification and rescoring, so going back through this whole cycle. It could be that the committee recommends deferring until later. Maybe it's a great strategy, it meets all the criteria, but now's really not the right time. Or it could be reject. Don't recommend moving this forward at this time or at all. So I want to note here that the recommend is kind of a loose word. So when we say recommend pursuing the strategy, depending on what the strategy is, what the policy is, that recommendation could be to an agency, OHA, DCBS. It could be to the policy board for you all to adopt and endorse and move forward from your perspective. It could be to the legislature if it's a policy strategy or something really specific that maybe legislators have asked for. So recommend is a little bit loose here because it really could depend depending on what the strategy is. And we wanted to make sure that there was flexibility so that this process could work and provide feedback in the right directions. So all of that was really high level overview of the process. There were a lot of details in the conversation that we can probably surface, but on the next slide, I just had a couple of potential questions for you all, feedback and thoughts about the criteria and process, what this might mean for the board as you engage. But before opening it up to everyone, Kirsten, as the liaison to the Cost Growth Target Implementation Committee. Do you have any thoughts you'd like to share?
No, well, yes. Thank you, Sarah, and thanks for the great work that went, that all this reflects. I think your questions are excellent here about like, how does the board kind of see ourselves in this process and scaffold onto it? And then I think looking at the criteria and process in particular, you know, taking a step back and earlier we heard about kind of really excellent collaboration happening across committees. And I actually think here, you know, you're consulting different committees here too, and feedback and ideas are bubbling up. For example, that criteria of kind of us there not being negative impacts is neutral, and how do we move towards, Ebony, I really liked your suggestion of like undoing harm. And I think some of that, I would say like, how do we as a board see more layers added onto this? So for this equity layer, I think is significant. How do, you know, should there be criteria around does this undo harm, and therefore like how does that balance with cost impact and stuff like that? So I would love to hear board's thoughts about how we scaffold onto this, particularly with equity and meeting our 2030 goal. But of course there'll probably be other brilliant ideas from this body too. So thank you. And I'd love to, Sarah, actually in this process too, thinking about the cycle you laid out, which I think is also an excellent representation of the philosophy behind this work and reflective of I think comments made by this body in the past. But I'd love to hear your thoughts about where the board, do you have a place where you see the board fitting in that cycle? Or
can we go back to that cycle slide? That's a good, let's put the visual back up, please. One more, we'll get rid of the question marks. Thanks. So I think the board fits in at many of these stages, and let me just give you my brain dump on this, and then Jeremy, ask Jeremy for some reflections too. But I mean, I think one, the board is helping really set some of this foundationally, so helping us identify what we're measuring. The board and the committees of the board is really providing some inputs into that measure and analysis process. We certainly think the board, and we've talked about this with you all, I think back late last year, about the board's role in reporting and convening the public hearing or hosting the public hearing. So certainly strong role for the board there in terms of leadership, both in calling attention to the reporting, helping surface that transparency, helping direct some of the attention through that whole process. And then I think in the identifying and implement, there's also really strong board roles. So a lot of your work could relate to this, where the board is one of the sources of strategy identification coming up and being recommended back to the implementation committee to go through that assessment process. And then maybe if the recommendation was back to the board, there's sort of a cycle, a little mini cycle there. And then I think possibly implement some of the strategies could be things that the board could implement, or that the board could play a strong role in moving forward to implementation. So I think, again, strategy dependent, but I would really see the board as having a role in each of these steps. But Jeremy, do you have a different perspective?
No, I think that's exactly right. I don't have much else to add, sir.
Kristen, thank you for that. Let me just also add, I think this year we're being much more intentional about crosstalk between the committees and the real important role the board plays in that crosstalk, in both in reminding the committees what the overarching themes are we're trying to advance, but also making sure the committees are hearing from each other and we're facilitating that talk. I think, you know, this is very highly interdisciplinary work, involves a lot of committees in different ways. And I think one of our jobs is just to help manage and support the communications with the great staff or great support of OHA.
And Kristen, I was just gonna, you know, I know you were, you know, highlighted kind of, you know, how do we effectively measure, or what does it mean to, you know, to undo harm? How do we know that we're undoing harm. And so, for me, my mind kind of, again, just thinking out loud, is some targeted conversations to kind of get clear on, okay, so what is because I think the priority population based on our data is going to kind of tell us, okay, what are the areas or groups that we're trying to focus on, and then depending on kind of whatever that specific metric is, then obviously that's going to give some additional guidance. But my mind goes to, how do you have some set criteria around prioritized population and the specifics of the areas of what we're looking to achieve improvement in. And so I think it's, kind of going back and having some conversations between the committee, which also includes the equity committee, around just fleshing out how do you measure that level of equity, because it's hard, and we won't see gain unless we do have some set criteria. So no, that's not really an answer, but just a thought.
And just to add to that, I think that's exactly the kind of conversation we're hoping to have with the Health Equity Committee when we come back to them in July. So I think I'll try to incorporate some of this framing into what we're thinking for them in July. Thank you. John, and then Brenda, I think.
Yeah, two things. One, just a comment about a general issue, and that's what role is variation going to play here? Almost always there's significant variation wherever you look in the health system. So, my guess is in many of these areas, you're going to find that there's a subset of folks who have high cost or challenges, and a subset of folks who look like they have figured that out. So are you going to look at variation and consider that in terms of your strategies, et cetera? Then, the second would be, I think there's a pretty well-established history of safety and, if you will, error kinds of issues that can have significant cost impacts and can be corrected. The best example, I think, Oregon dealt with pretty well, which is, there really was quite the significant tendency to electively deliver a subset of women before 39 weeks. And when I say electively, I mean there was no indication they needed to be delivered. And that strategy did provide a flow of revenue to neonatal intensive care units. It was a revenue strategy. And at least in some states, it was preferentially focused on the Medicaid population. It was as likely or more likely to occur in the Medicaid population. And, so I think looking at areas that, we know are iffy in terms of their effectiveness, or we know there's an equity issue. Another example, we know that there's equity issues when it comes to preventive screening tests. We know that that's occurring in colorectal cancer. We know that. So, I think that that could help to guide some of these strategies.
Thank you. I think that maybe to go backwards and reflecting on your comments, I think in terms of the safety and error issues, I think definitely there's some opportunity to incorporate some of that into the framework for monitoring. So what are some places that we want to, again, just have a broad lens on to make sure that things aren't getting worse, potentially that they're improving, and that efforts to meet the cost growth target are not happening at the expense of patients and members. So I think there is some space to incorporate that. But I hate saying this, especially in a public meeting, but I think one of the tensions that's really come up for me in in these cross-committee conversations is that we all have multiple policy and programmatic levers, and that there's a little bit of a desire to sort of put everything into one bucket. So we'll make the cost growth target solve all of the problems. We'll make the quality measures solve all of the problems. And so there's a little bit of this, like, we want everything to be incorporated and not siloed, but at the same time, the cost growth target has some specific mechanisms. It is focusing on some specific things. That doesn't mean that we can't pull in these other pieces, but that, and again, I really probably shouldn't say this in public meeting, but I think like the cost growth target program is not the primary driver of reducing the disparity in colorectal cancer screenings. We know that exists. We can measure it. We want to make sure the cost growth target is not making that worse. But is it the only driver that we have that's working in that space? No. And I just want to be really careful about that sort of slippery slope that I've seen in these cross-committee conversations. Whereas we're talking about one of our policy levers, we start sort of piling everything on. And Jeremy, you can probably say this better than I can, but I just kind of wanted to flag that as a caution. Kirsten. Oh, sorry, go ahead.
Oh, Sarah, I'm so glad you just said that, because that actually is the root of my question or my comment. And it's mostly in ensuring that our board is not, like, one of the roles that we have is to think about the alignment across these different bodies of work. And I think more narrowly, what would be helpful to me would be the visibility when we're in that selection criteria phase, that if there's, and I'm not necessarily suggesting a fifth criteria, but mostly that the consideration of those crosswalks have actually already happened. So if meaning that instead of just piling on, as you're stating, that we're thinking about it from a leverage perspective. So if one activity is happening in the quality space that is also maximized by some extra attention in the total cost of care space, now we're on to something special. But when we do it in isolation, we run the risk of just getting so microscopic in a particular set of categories that I think we, as you know, and as you're saying, we miss the opportunity to extend it from a much bigger platform. So that was, thanks for saying what you did. I appreciate this body of work and the complexity of it. And I would also just say, it strikes me that you're aiming for a balance of simplicity with an incredibly complex body of work. So I see that in this modeling, and I really value it tremendously. My last question, that was more comment. This is a question which is actually about pacing, and maybe if you said it, I missed it, around when the selection efforts actually take place, at what frequency, and what the board's role in that selection actually looks like. Thanks.
Yeah, thank you for, I guess, also commenting on that a little more articulately than I did. I appreciate that perspective as well. So in terms of the selection, I think I only briefly mentioned that this would be sort of an ongoing process. We have talked about this both internally and with the implementation committee a little bit. We're not thinking that there's sort of a window that opens and you only have one chance to suggest a strategy. These conversations can happen at any point. Our analysis and reporting will happen. There'll be a lot of stuff coming out, and as people reflect on it, there'll be opportunities to identify a strategy. So I think if I'm trying to say something kind of concrete today, I would say that particularly tied to when that reporting and public hearing happens, that'll be a major focus for identifying strategies, but certainly not the only one. And that strategy identification can happen at any point throughout the process. I think we need to think some more about how to best use the implementation committee and the policy board and what those roles and intersection points are. Is there a point where the policy board would like to say, I would like a list of all strategies that have been considered and assessed against the criteria at the end of the year reported back out to us, whether or not it's for the policy board to take action or not. That might be a really reasonable way to move this forward. This could be something that we report back out of just part of the cost growth target program every year, and that's just pushed out and available. I don't think that we're trying to tee this up as this is a recommendation that then the policy board has to sign off on all pieces of it. I think, as I mentioned earlier, some of these strategies might be things that are directly for the agency. They might be directly for payers and providers. They might be to the legislature. So certainly we want the board to be involved in it, but I don't think we were entering it into as a sort of a single pipeline committee to board signs off at a certain point in time, and then it's done. I think it's going to be a little more evolving and open than that. But do others maybe have thoughts on that?
I can comment.
Is just that that's absolutely right. And the reason is to make sure that we have the flexibility to point out where those efficiencies can be gained. And even if it might sort of fall out of the direct scope of that structure. So that was really important to the board, that we didn't narrow the scope so much that there was limited recommendations that could be made.
Jessica.
Jessica,
Bill's got his hand up as well.
or Sarah, I see Bill has a question.
Sarah, thanks for this presentation, and this is really great work, and it's really encouraging to see the progress we've made. I wanted to go back to the question that John asked, his first of his questions about variation. Since we know there is tremendous variation between programs, you know, the Medicare, Medicaid, and commercial area, but also between provider groups in terms of costs and opportunities to improve their costs and lower their costs. How is that being handled in all of this?
So Bill, I like that you didn't let me get away with avoiding John's question. Thanks. So I was hoping to not make this super technical, but let me try to keep it at the right level. So a couple of key points to add to this conversation. One is that when we talk about measuring performance relative to the cost growth target, we're measuring the trend. We're measuring the percent change year over year at a broad level. So statewide for each of the markets, Medicare, Medicaid, and commercial, for the payers in the state, and for the large provider organizations, so the large health systems. We are not talking about measuring sort of the change at that individual patient or member level where, oh, you are now 10% more expensive as a patient, as a person than you were last year. So we're trying to bring it all up a level and look at the trend first off. Second, there are a number of controls built into the methodology of this. So the data that will be submitted by the payers to use for this performance and calculation of trend is risk adjusted. So the data will be taken into account. The changes in population risk profile, clinical risk status will be adjusted for. We're also having a very wonky discussion with our technical advisory group and with a couple of the other states about how we think we should handle high cost outliers and what that means for this programmatic effect. We haven't landed yet. This is an open, ongoing discussion this month, but it's certainly something we're considering. And then in terms of the variation, sort of between markets or across markets and payers, like, yes, we know markets serve different populations, markets cover different benefits, payers have different case mix, payers have different member populations, and provider organizations have different patient panels, and all of that is, again, controlled for. We're focusing on comparing the same level or the same organization, the same entity to itself year over year. So we are making some assumptions that there's not huge shifts in the market, although if there are, we do have some safeties to catch that and account for that, but we're not trying to directly compare against each other, but more comparing yourself over time and what's happening. And if we're seeing that, oh, cost growth is really increasing more sharply in one market over another, we want to know why. If we're seeing the cost growth trend is really drastically different in a couple of insurers, but not others, we want to know why. And some of that might be due to that underlying variation, and some of it might not be. So again, I'm sorry, this is a very oversimplified, trying to consolidate a lot of methodology conversations, but I think we do have some controls built in on the front end and on the back end, but we think there's a lot of nuance that we'll be uncovering once we get into the measurement and the conversation.
I just have one other reflection on the selection discussion, and that is, you know, while I absolutely appreciate keeping the funnel wide open for great ideas as they emerge and not having kind of deadlines and that sort of cadence, I also recognize that if we don't select and narrow our discipline, at least at some level, we will lose energy and momentum to achieve specific outcomes on those strategies that are selected. So it may be premature for this comment, but I know I'll personally be on the lookout for how we maximize the conversation, you know, and driving it toward a fewer number of really significant strategies that have high lift, while also cultivating the things that maybe are super meaningful, but not necessarily quite as impactful. So just, anyway, for whatever all that's worth, thanks.
I think that's great. Can we go back to the strategy, the 4 strategy slide, 4 criterion slide? I think this is something the committee also talked about, and Jessica, please chime in here as well. But I think too far. I think the maximizing is really something that we're trying to capture in criteria number 4, that there's limited capacity and bandwidth, and we don't want one strategy to take away from existing efforts, or we don't want a new strategy to distract. And so I think trying to make sure that there's space and that there is capacity and energy to take on new strategies will really help narrow that funnel. I don't think we're trying to narrow the funnel from the all potential ideas can be put on the table, but more making sure that the criterion will help us prioritize effectively. Jessica?
Yeah, that's exactly right. We wanted to kind of be able to identify all of those areas where we could make a difference and then narrow it down based on impact, right? What are some of the broad ideas, and then what impact would they have, and then rank them so that we really have a shot at making sure that we're not missing anything, but that our effort is targeted and measurable.
I would just like to put a very clear point on this, and I don't necessarily, I agree with Brenda that maybe like a number 5 is not needed, but I do think that this criteria for narrowing down the strategies is going to be a little, I mean, these look great. I imagine the process to be a little squishy, messy, and there to be a lot coming through. And so I think as that filtering is happening, I do think that an equity lens and impact is an important part of that conversation, so that when we're at the end of it, we are asking, like, how is this strategy also undoing harm? And that help rise certain strategies to the top.
Other comments or feedback on the criteria and process? This is really great.
Just a quick thought and also a question. I agree with Kristen's comment about sort of this equity lens being attached to almost each of the 4 strategies. I know that there's sort of this umbrella equity lens framework about making sure that some of these decisions aren't creating harm to communities. But almost within each criteria for assessing the strategies, I feel like there has to be a really thoughtful approach. Otherwise, we could be creating a lot of harm. And then the other question is, I remember at some point, I don't know if it was other states that have already been doing this, but there's supposed to be convenings, correct? Like, aren't there supposed to be like big stakeholder convenings that I believe the policy board is sort of very highly involved in? Would those convenings kind of involve this idea of like the analysis that's going to be happening from the reports and the recommendations? Or how do those two kind of...
Let's go back to that cycle slide, please.
Yeah.
You're definitely right. We do intend to have public hearings, and while not called out explicitly here, that's part of the report. So there will be the report that summarizes the performance, the measurement, the analysis, the quality and equity work, all of that. And then the report and the public hearing we sort of see as accompanying each other. So there will be a report that is the foundation for convening the public hearing to discuss the findings in the report and to dig deeper or find additional direction for exploration, to involve stakeholders. I think it's really likely that all kinds of potential strategies could be identified through that public hearing process.
Okay, thank you.
Okay. How are we doing on time? I do have a third section, but I also can stop here if this is a good place to stop.
We're doing well on time, Sarah. So yeah, please continue.
Okay, great. Let's go to the third section, the Oregon Health Insurance Survey data. So just really briefly, we wanted to share some data from the Oregon Health Insurance Survey. This is from the 2019 survey. I'll talk a little bit about that in a second. With the implementation committee, we thought that it would be really helpful to provide some more detailed information about consumer cost impacts. This can help, we thought this would help the implementation committee and you all with some context, some general background information, and it will help inform that continued development of the framework for monitoring and the identification of strategies and prioritization. So there are some specific indicators from the Oregon Health Insurance Survey that I'm about to share with you that we think might make sense to plug into the framework for monitoring going forward. But we also thought that it just might be of interest for you to take a closer look at this data. Okay, I'm gonna go pretty fast through this, but you have all the slides. So go forward 2 slides, please. Okay. So the Oregon Health Insurance Survey has been fielded every other year since 2011. So in the odd years, there were some methodology changes in 2017 with a new vendor. It is currently in the field right now for 2021. So I'm going to be talking about 2019 data, but we're going to have new data for this year soon-ish. This is a random digit dial survey. It collects, it calls both cell phones and landlines, and it's conducted in English and Spanish. Next slide, please. In 2019, the survey was fielded from March to August. The target was all persons in households living in Oregon, and the survey collects information at the household, family, and individual level. So lots of different ways to look at the data. Next slide. The Oregon Health Insurance Survey also covers a lot of topics, and we've definitely shared data from the survey with you all before, especially when we think about what percent of the state has insurance coverage. So that 6% remaining uninsured data point that we've used a lot comes from the Oregon Health Insurance Survey. We also have, there's also questions about why folks don't have insurance, if they've had changes in their coverage, access and utilization, and then our focus today, cost. So there are 2 major sections of that I want to call out for you today. And one is delaying care because of cost. So where folks, did folks have to delay care? What kind of care was delayed? Who was more likely to delay care? That kind of thing. And then difficulty paying medical bills. So there are a number of questions here that get at folks who were unable to pay medical bills, who had trouble paying off medical bills, or had to use up savings to pay their medical bills. So had to pay for medical care instead of something else. And next slide. The Oregon Health Insurance Survey data is online in an interactive dashboard. The cost and affordability report, that bottom left bucket, there are 26 variables that will be included in that analysis in that dashboard. That dashboard is in development and will be published later this summer. But the insurance coverage data and the data about the uninsured are there and live, and you can go explore at any point. So the data I'm going to be showing you today is a preview of that cost and affordability bucket. I've pulled just a couple of variables out. There are, again, 26 different ones. So there's a lot more detail that will be available in the full dashboard. This is a sneak peek. Any quick questions about the survey that I may or may not be able to answer before we get into the data?
I have a quick question, Sarah, if that's okay.
Yeah, go for it.
For the slides that you're going to be showing us about and cost of affordability, is that across all payers, or does this exclude OHP? And look at just commercial. Tell us.
This is a not payer specific survey. So we have information about people in each of the different markets as well as the uninsured, and I'm going to show you some of the data broken out that way. Okay, let's take a quick look at the first section. So delaying care because of costs. One more slide. So overall, statewide, 15.7% of Oregonians reported that they delayed care because of cost in 2019. And let's go into that a little bit deeper. So on the next slide, we see that younger adults were more likely to report delaying care because of cost than other age groups. And this again is across everyone, regardless of insurance status right now. So those 19 to 34 years old were the most likely to report delaying care because of cost. On the next slide, we see that uninsured Oregonians were the most likely to report delaying care because of cost. That makes sense. But that's fairly closely followed by the individual market. So that's commercial insurance, individual market. Oregon Health Plan here at 15%. There is no cost sharing with the Oregon Health Plan, but Oregon Health Plan members often cite the cost of care as a barrier. That could be a misunderstanding of what's covered. That could be a barrier to cost of care for things that aren't covered. So there's a lot going on with that OHP line. And again, we're reporting here, there are a couple different ways to look at this, but we are looking here at people who have had this type of insurance for the past 12 months with no changes. So the data look a little different for people who might have bounced around between insurance types or between uninsured and insurance in that 12-month period. But here we're looking at just those who consistently had this type of insurance for a year. Next. So moving on to looking at this same question by race and ethnicity, and we do see some pretty big disparities popping out. So about a quarter of Native Hawaiian and Pacific Islander Oregonians, and then those who report other race reported delay in care due to cost, compared to just under 16% for white and just under 13% for, excuse me, for Asian Oregonians. And then finally, we look at the type of care that they report delaying. Next slide, please. So Oregonians were most likely to report delaying dental care due to cost. These questions were not mutually, these questions were asked independently, so they don't add up. People didn't have to pick one type of care or the other. They could answer yes to all of them if that was what their situation was. So dental care was the most likely. Mental health care was the lowest or the least likely of these types of care to report being delayed because of cost. All right, that was really fast. Let me stop there. Any questions about the delaying care due to cost data points or reflections?
I'm surprised that mental health care was so low.
Can you elaborate on that, John? Like
Well,
why?
you know, I think a lot of this is probably anecdotal. I mean, through my career, I've just found it difficult to get people to, you know, go to have mental health care, and they oftentimes, you know, claim it's an expense issue. This suggests that maybe it's not, or expenses aren't as important. So that just surprised me. Dental makes total sense because, you know, a substantial portion of Medicare folks don't have dental insurance. A substantial portion of commercial folks don't have it, and so I know the cost is a big issue there. But I was just surprised to see mental health care at the bottom, and I'm finding this data generally very persuasive and very important, especially for this project. Its only downside is it's you know, every 2 years rather than every year. So I really like this data. That mental health piece was just one thing that I thought that doesn't quite make sense to me. I don't know why. So that's all, Oscar. I mean, I don't know.
Yeah, I was surprised by that as well. So that's why I was curious to hear your thoughts on that. Sarah, is there any demographic information in terms of the people who were surveyed? Do we have like the race breakdown or gender and age breakdown? Because that could also say a lot about these results.
Of the survey sample itself?
Yes.
Yeah, I don't have that off the top of my head, but I know that that's in the, some of that's online in the dashboard.
Yeah, I think for, you know, John, going back to your comment, I think for mental health care, it could also be that like communities of color, because there aren't a lot of providers of color, that they're probably seeing that as a bigger barrier, as the first barrier before even like cost. So Just
Yeah.
just an anecdote there, a thought there.
So it sounds like maybe some additional digging into this mental health delay and looking at some of the other variables here might be of interest.
Is there a variable that looks at delay in care regardless of cost?
I'm not sure. I can find out. Sorry, I'm taking notes on that to go follow up with the survey team. I am not the analyst for this. So let's look at the second set of data points here related to paying medical bills. So again, starting with top line results on the first slide, 7.7% of Oregonians report they were unable to pay medical bills in the past year. Again, we're looking at the 2019 data, so all of this is pre-pandemic. I'd be really interested to see how much this has shifted, if at all. And let's start breaking that data down. So next slide looks at this by insurance status. So again, we're looking at folks who had the same type of coverage for the entire 12 months with no changes. So uninsured Oregonians were most likely to report that they were unable to pay medical bills in the past year, but that was really closely followed again by the individual market. So those commercially insured in the individual market. And here at the bottom, we see that Oregon Health Plan has not dropped because it's not a direct comparison, but far fewer report that they were unable to pay medical bills compared to those who reported a barrier because of cost. On the next slide, 10% of Oregonians report trouble paying their medical bills off over time. And the next slide, just over 10% of Oregonians report using up all or most of their savings because of medical bills. So let's break this one down a little bit more. Next slide. Again, uninsured Oregonians were most likely to report using up their savings on medical bills. Here, again, we see Oregon Health Plan comes back up to second, followed then by individual, group, and Medicare. And again, same thing, the folks who had the same insurance coverage for the past 12 months. This is not, let's see if I say this right. This is not necessarily a medical bill that they got from that insurance type. I don't think it's that tightly constrained. So some of this could be a bill that they received maybe previously, or a lingering medical bill from years ago that they are having difficulty paying off, I think. And next slide. So again, just finally looking at this data by race and ethnicity. So Native Hawaiian or Pacific Islander Oregonians were 3 times as likely to report using up their savings on medical bills compared to the other racial and ethnic groups that we are looking at here. So again, I just wanted to stop for any questions or reflections, anything in this data that surprises you, and then maybe to wrap up, what do you think about using some of these indicators to help with monitoring around the cost growth target?
Yeah, this is John. As I said, I just think this is terrific data, and I was really impressed with it. I did wonder about the OHP. I thought, well, is this folks who are, that's spending before they're eligible, and they're losing their assets, so they become eligible. I would guess it couldn't be that much, elderly folks spending down in order to get long-term care, that sort of thing. Or, I also wondered, Sarah, I'm sure OHP folks get bills. Everybody, we all get bills, and they see those bills and go, whoa, am I glad I don't have to pay that, or because I couldn't pay it. But the OHP thing is very interesting. But I just think that this is a wonderful baseline, and justifies what the state is doing, and it's terrific.
Sarah, I have a quick question, and I can't remember if I asked this the last time we looked at this data or not, but do you have any sense of why this particular demographic is sort of answered affirmative in such a higher percentage compared to the other people on this list that we asked?
I don't have a good answer for that, but maybe other board members have reflections or possible considerations.
I have some limited experience with this in some of our membership in these populations. And some of them were COFA populations who are not earning very low wages, minimum wage, but not eligible for Medicaid because of that for a long time. Now Oregon has taken great steps to rectify that, but you know, people could remain unenrolled if they maybe didn't know about changes in our state.
Any other questions or reflections about this data or this data as it relates back to the cost growth target program? If there's nothing else immediate, I am going to end here, but I just encourage you again, please go play with the dashboard online. There's some really great data here, and it's exploratory, and the cost data will be added to that later this summer. But there's some really good information already out there. So just want to plug that for your reference. And thank you so much for your time and your feedback. And we will keep coming back with cost growth target program updates. Thanks.
Thank you, Sarah and Jeremy, for a great presentation. Also, super thanks to the board for really engaging generative discussion. I think it was time very well spent. So we are ready for a 10-minute break, and we will then come back to public comment. We do have some public comment today. So why don't we, just about 10:27, let's come back at 10:37, and we'll get ready for public comment. Thank you, everyone. Welcome back, everyone. We are about to transition to public comment, and just a few introductory notes to make before we have our public comment. That we, as the Oregon Health Policy Board, really deeply appreciate the public testimony. It's one of the most powerful ways we hear about what the priority should be, and we are committed to profound listening and learning from your comment. As we listen to your comment, we will not respond during this meeting or attempt to fix or resolve questions during this meeting. However, both Vice Chair Oscar Arana and I, as well as OHA staff, meet after each meeting to discuss and reflect on public comment and prioritize that comment to guide our future work. Each presenter is given 2 minutes, and it may not feel like enough time. We welcome you to provide written testimony in addition to your oral testimony, and we will read that carefully and incorporate that in our work as well. Please, and then staff will then communicate next steps with each public commenter. Today we have 3 individuals for public comment. We received written public comment from CCO Oregon in support of the Medicaid waiver. This has been posted on the Oregon Health Policy Board website, and I invite you to review that public comment because it addresses specific recommendations with respect to the Medicaid waiver. So I'd like to first invite Rick Blackwell for public comment, and please, for the record, state your name and your affiliation.
Thank you, Chair Banksburg, Vice Chair Arana, and members of the board. I'm Rick Blackwell. I'm the Director of Oregon Government Relations for Pacific Source. Thank you for the opportunity to accept public comment. I just want to note our appreciation too of the Oregon Health Authority's work around drumming up public engagement and working with CCOs on this next 1115 demonstration waiver. I did some policy work in a past life, and I know how difficult it is to do this kind of public engagement, and to do this as we come out of a pandemic is commendable. So I just want to thank them for that. You're going to hear some from our colleagues about some specific ideas that CCOs have been considering advocating for in the next few comments. I wanted to focus instead on how the waiver might be considered to drive community spending decisions. In today's presentation, you may hear more about how the waiver proposal will actually take steps to do that. I just wanted to make sure that the policy board understood that from our position, we're already doing that work, trying to involve the community in spending decisions. Now, if you've met one CCO, you've met one CCO, but in Pacific Source's experience, we carry out our responsibilities under the CCO model by standing up health councils. Each is different, but they try to improve the health of the community overall. Pacific Source does not govern these health councils. Instead, they're really a community-driven effort, and they make spending decisions based on the work, which has real results. In Central Oregon, the health councils invested about $35 million since 2013 on projects. So as we continue to work in communities in Oregon, we also want to see if there's a way to infuse data within the waiver. So for instance, provider electronic health records are going well, but more support for interoperability and reporting is still needed. We're working together. I guess I'll close really quickly to say we're working together to identify and bring ideas forward. And as we serve unique communities, individual CCOs will have ideas that reflect on the unique needs of the communities we serve. So with that, I think I beat the timer. Thank you for your consideration. And if there's any questions subsequently, please feel free to reach out.
Thank you very much. Next, I'd like to invite Josh Baylock for public comment. Please state your name and affiliation for the record.
Hi, Josh Baylock. I'm the Vice President of Government Affairs for All Care Health. We're a Southern Oregon CCO. So in 2012, Oregon was able to get an 1115 waiver to create coordinated care organizations. The pitch to the feds was relatively simple. Oregon wanted to fully integrate mental, physical, and behavioral health Medicaid services under one community-based organization that would take full financial risk with a global budget to stay at 3.4% rate of growth. The feds believed in the model enough to invest $1.9 billion in Oregon to help us make it happen. But there was one thing that was not included inside of that waiver, a true global budget. CCO budgets are still based year to year only on medical spend. Investments in community don't count toward base budget. Paying behavioral health providers what is above what is usual and customary is not included in a CCO's base budget. As a result, CCOs are negatively incentivized to make upstream social determinants of health investments. CCOs still make these investments anyway, but they are forced to do so with short-term or one-time grants. The current funding structure does not allow for the sustained changes that were originally envisioned in the first CCO waiver in 2012. Fixing this critical issue, this critical funding issue, is vitally important to achieving this goal, the board's goals of achieving health equity and investing in the social determinants of health. And I will just also say I'm very concerned about some ideas that have been kind of floated around of this idea around siloing out social determinants of health funding. This is an idea that that would really kind of create another silo that will make things unsustainable. It will create more fractures inside of it. It will undermine a lot of the good work that's being done by our community advisory councils. So I would just very much caution around going that direction. So with that, thank you so much, and good luck. Thanks.
Thank you very much for your public comment. And I would now like to invite Bill Buska for public comment, and please state your name and affiliation.
Good morning. My name is Bill Bushka, Director of Government Relations for Intercommunity Health Network Coordinated Care Organization. Since 2012, IHN-CCO has managed the Oregon Health Plan benefit in Lynn, Benton, and Lincoln counties. Today, we have an enrollment of over 71,000 individuals. I want to focus my comments on the importance of making sure that eligibility enrollment process is as simple and as effective as possible. And also about maintaining CCO enrollment as people transition through the system of services and supports. I have a couple of key concepts that I want to highlight. It would be good to consider expansion of postpartum coverage to at least 12 months post-delivery. We know that around half of the babies born in Oregon are covered by the Oregon Health Plan. Currently, OHP coverage is expanded for individuals who are pregnant, but that expanded coverage ends 60 days after birth. There's 3 other states that have recently had their 1115 waivers approved with the 12-month postpartum coverage. Those states are Georgia, Illinois, and Missouri. We feel that extending that coverage will really lead to healthier parents, the mom, and the babies, of course, and families. The other large group that I want to talk about is continued coverage and CCO enrollment for Oregonians who are in jails, detention, incarceration, or the mental health system that surrounds the Oregon State Hospital. Today, individuals involved in these systems are disenrolled from OHP and lose connection with Medicaid reimbursed healthcare services and care coordination connections in their home communities. These members frequently have complex health and social service needs. So a couple ideas under this bucket: maintain CCO enrollment during pre-adjudication phase for those in jail or detention. Another is to extend OHP coverage when the length of stay in corrections facility or Oregon State Hospital is less than 1 year, or allow CCO enrollment 2 months prior to release or discharge from these facilities. And a last idea would be to create a care coordination only plan or enrollment category for Oregon Health Plan individuals in settings where Oregon Health Plan coverage is currently not allowed. So we actively support the direction of the waiver renewal as we understand it today. There's many steps ahead to get us to the details. And we hope these ideas will help you think about the populations and settings that can be positively impacted in the next 5-year waiver program. And we're excited to work with the policy board and the Oregon Health Authority and other stakeholders as we move forward this year. Thank you.
Thank you all for your public comment, and for CCO Oregon for your written public comment. I look forward to following up with OHA staff during our planning meeting regarding many of the comments you've raised today. And it's timely that we have public comment on the waiver as we start our Medicaid waiver update discussion led by Lori Coyner and Jeremy Vandehaye. We continue our deep dive on this topic, and as you recall, in May we heard about the global budget strategy. Today, we will focus on the health equity-centered system of care and cost-sharing strategies. I believe also the draft waiver policy concept papers will be publicly released today. We look forward to those, and we'll discuss those policy papers in more detail during the upcoming July meeting. So Lori and Jeremy, I'll hand it over to you for our Medicaid waiver update.
Great, thanks. You have heard, Laura and I have been kind of dividing these 4 topics. So you've heard a lot from me over a global budget and coverage deep dive. So you're going to hear more from Lori today on the other 2 topics, and then we'll both tag team a bit, a summary. As Chair Bingsberg mentioned, we've been drafting some concept papers for these 4 topic areas. We'll be releasing those today. Will be out for public comment and also going around a variety of forums and committees to get input throughout the month, with the expectation that we'll put out revised draft concept papers at the end of the month or early July based on the feedback that we get throughout the month this month. So with that, I'll turn it over to Lori.
Great. Good morning, everyone. I'm going to cover a couple things. The 2 policy areas that you haven't heard about yet. So one is creating an equity-centered system of care, and the other is how some pretty broad strokes of ideas of how we are going to propose to spend some shared savings that will make a pitch to the federal government that we are saving money and where we want those shared savings to go. So if you could advance the slide, that'd be great. So I think Jeremy just went through, this is what we're talking about today, and we'll have, we're hoping, we have, I believe, a whole hour. So we're hoping to have plenty of time for discussion and with you and talk about next steps. Next slide. This is just a recap of what you've heard. So our waiver will advance the major focus areas to advance health equity, and we're planning to do that under 4 big policy areas. So the first is to ensure access to coverage for all people in Oregon. We presented on that, or Jeremy did a couple of months ago. Once we have as many people covered as we can, then the focus really, the way to think about it is then we want to make sure that the system of health that we operate in Oregon and Oregon's Medicaid is equity centered. Coupling that with encouraging smart, flexible spending through global budgets for CCOs, which you just heard about in public comment. And then, as I mentioned, when we manage under a global budget, we anticipate saving the federal government significant dollars, and then we are going to propose that we are able to reinvest those savings in communities with a health equity focus. Next slide. So I'm going to spend some time here walking through our main ideas for how we plan to create an equity-centered system of health, or at least move that needle forward. Next slide. Here's some quotes from members. These are direct quotes from Oregon Health Plan members. And they just illustrate that we currently have racism in our system. It's both on in a personal level and a structural level. And so some of the concepts that we plan to move forward here are to address the particularly these structural barriers that people of color encounter on a daily basis when they're accessing our Oregon's health system. Next slide. So what is an equity-centered system of health? I think the piece to really focus on is that we want all people in Oregon to reach their full health potential and well-being, and that they're not disadvantaged by their race, ethnicity, language, disability, gender identity, sexual orientation, age, social class, and intersections among these communities or identities and other socially determined circumstances. So the focus on this equity-centered system of health is on improving a lot of the socially determined circumstances that people encounter, as well as, you know, pieces of our, what you think of as the traditional medical system. So this is going to require an equitable distribution or redistributing resources and power. And we'll talk a little bit, at least today, about how we plan to redistribute those resources and in some ways, and put some more decision making in the hands of communities, and particularly communities of color. And then being open and recognizing, reconciling, and rectifying historical and contemporary injustices. Next slide. So we're going to talk a little bit about here what we need to do, and then the pathways to get there is going to be the following slide. So to create an equity-centered system of health, first and foremost, we need to ensure that the health system works for all Oregonians, and particularly we need to focus on communities of color. We need to then address the needs that are identified from those communities that result in inequities, and really think about the barriers that lead to health disparities. We plan to understand the lived experiences of members. We are receiving lots of feedback from partners. We had a webinar, for example, with our community partners, both in Spanish and English, and these are the community partners that work to enroll Medicaid members on a daily basis and are really on the ground working with members and obtaining feedback and input from our community partners. Also had waiver days with over, I think, 400 people participated to provide feedback and input on our waiver. And it's understanding some of these messages that help us look to the policies that we want to promote in creating an equity-centered system of health. And then finally, really to look at changes in the Oregon Health Plan, focusing on members with complex needs. We're particularly going to be focusing on members who are transitioning from different types of care, and I'll talk about this a little bit more, but we have a number of instances where people are on the Oregon Health Plan, enter another system, so that because of federal guidelines are taken off the Oregon Health Plan, or their coverage is suspended, and then they come back on, and that causes big disruptions in care. It's particularly hard for people of color and members who have behavioral health conditions to navigate those big changes, and it's particularly people with complex needs we see that are in these transitions. And so a lot of the focus you'll see in the next slide is going to be around eliminating some of the gaps in coverage that happen and gaps in care that happen for people who are undergoing these big transitions. So we'll talk about that on the next slide. Oh, I think it's the one following, but here I'll tell you the goal. So let's see. Is this? I want to make sure we're on the right slide, and I apologize for pausing. Did we go forward and then back? Let's see what number is this one. So let me just back up, I guess, and we'll talk about the pathways later. But our goal is that, so our overarching goal for the creating an equity-centered system of care is that Oregon Health Plan members experience coordinated and integrated care across the health system. And that's really, if you've been following our coordinated care model with CCOs, that's been the focus since 2012. We want to amplify the focus on social systems. So we've always had flexible services, health-related services, where been promoting having members receive care that's beyond just the medical system. And then we're going to amplify that work on social systems. There's also a focus on eliminating language and cultural barriers. to care. So we know that people who don't speak English have a more difficult time obtaining high quality care, and that we've heard in our feedback from the public and from members that we don't have enough providers who can provide culturally sensitive care, that where the patient or the member feels like they're talking to a provider who's like them and understands their situation. And then in these transitions of care that I was talking about, we want to make sure that we can preserve the Oregon Health Plan enrollment as long as possible, so people can have warm handoffs, can have seamless coordinated care across those transitions. And what I'm talking about in terms of transitions, for example, is entering the criminal justice system and coming back out would be one example. And we'll talk about more in a little bit. Next slide. So the scope of the waiver that we're working on and some of the areas that we're going to build on is let me kind of give you a framework of what our current waiver provides and then what we're going to build on. The current waiver framework has focused really heavily on care coordination. That was kind of the underpinnings of our CCO model since 2012. In our CCO 2.0 contracts, we had a more intense focus on intensive case management. That's the ICC there. And that ICC intensive case management requires the CCOs to create a more holistic care coordination around individuals who are experiencing transitions or experiencing intensive behavioral health needs, for example. And the intensive care coordination is a start to address social needs and the medical needs at the same time, and try to make those areas of care complementary. We also currently, through our prioritized list and the way that we manage the Medicaid benefit, our Medicaid benefits are evidence-based. If you're covered by the Oregon Health Plan, that's longstanding since 1994 in our waiver. And then we are going to be looking at utilizing what are called in lieu of services to provide care that's outside of the traditional benefit. This is a little bit different than our health-related services that we've been using in the current waiver. We are not going to take those away. We're going to continue to allow CCOs to offer health-related services, but also to make it easier to provide those services to members, we are going to outline some packages of that care and call it have it sit as a in lieu of service. And what does that mean? In lieu of services are services that can be used in place of a medical service. So I'll give an example. There might be a child with asthma going to the emergency room a lot. And so the medical care could be medications for that child on a daily basis. And in lieu of service could be mold abatement in the child's home. And that would be considered, if it's an in lieu of service, it counts as a medical service, and it's much easier for a CCO or a provider to access those services for that child. And so that's part of the reason why we're looking at making some of these services more accessible through an in lieu of service package. Next slide. So I've talked a little bit about this, serving populations in transition. We're looking, the types of transition we're talking about is criminal justice system. So for example, if a member enters the county jail, is incarcerated in any way, the federal law requires that Oregon Health Plan benefits stop, and then they do not start again until they leave that facility. And what can happen is they walk out the door, they don't have any they walk in the door, and the jail or prison has no access to any EHR, doesn't know what meds that person's on, doesn't know about their chronic conditions. And then, so starts from scratch. And then when that member leaves, they walk out the door and the member's got to figure out how to get their, their eligibility coverage. They have no meds. They need potentially to see their primary care doctor. That appointment's not made. So that would be an example of the kinds of transition that happens because of the loss in coverage during the incarceration. We also see that happening with Oregon State Hospital, members that enter a psych residential facility, kids in foster care, kids aging out of foster care. So we're really looking at a host of transitions and not just one, and going to be talking to the Center for Medicare and Medicaid Services about expanding some coverage during the times of those transitions. And I'll talk a little bit more about that later. Next slide. Another promising strategy, so we're going to look at these transitions, and then another promising strategy is really focusing on housing and social needs. So I've mentioned the idea around social needs, but we know in Oregon that housing and homelessness is a huge issue, and it's a healthcare issue. People who don't have a permanent house their medical spend is much higher than people who are housed. It's really the basis of health for particularly for people with behavioral health needs and those in the transitions of care I talked about. So we're looking at creating a suite of benefits that address housing needs, for example, and other health-related social needs. Those could be people who are experiencing food insecurity, people who are experiencing homelessness, certain transportation benefits, things like that we will create as a suite of services, again, with the idea that these will meet members' needs where they are and be much easier for a provider to work to get the member those services. We also anticipate working with community benefit organizations right in the communities to help partner, to figure out how to make sure that members have access to these services. And, and that would be certainly in concert with the CCOs. Next slide. Another promising strategy in creating an equity-centered system of care is addressing behavioral health access. We know it's an issue in Oregon. And one of the key areas that the waiver will focus on is building capacity and a workforce that is culturally appropriate and language appropriate for members who need it. So we know that right now at the legislature, there's work on investment of state dollars to strengthen these issues. And so what can Medicaid do to allow those investments to really work? And that's focusing on allowing Oregon to use peer support specialists and expand the work that traditional health workers and community health workers can do. There's issues around clinical supervision and things like that we want to address in our waiver. Next slide. And finally, we've had multiple meetings with tribes and the tribal health representatives from tribes around specific strategies that will help our tribal people and tribal governments in Oregon. And through these monthly meetings, we've identified some areas that lead to focusing on tribal based practices and promoting tribal based practices as much as we can through Medicaid, reducing some of the administrative burden around billing that our tribal health centers experience. And then also we'll be asking to continue some existing programs that we know work well for the tribes. Next slide. So here's, I guess, our 4 big areas that we're focusing on to lead us toward an equity-centered system of health. I do want to mention that the other areas, when we think about I'll talk about this next, but the investments that we plan to do with the shared savings also move the needle. We're hoping, at least that's the plan, on creating an equity-centered system of health as well. So these aren't standalone, but our waiver as a whole package is focused on equity. So just to recap, there's these transitions of care, expanding coverage during that time, and making sure that people have more seamless transitions as they're moving in and out of these kinds of transitions, addressing housing in particular and other social needs for our members in a more robust way, improving behavioral health access and the culturally and creating a more culturally appropriate and linguistically appropriate workforce. And then we have some tribal specific strategies that we've been working with the tribal governments on. Next slide. I'm going to move right into the reinvesting savings, and then Jeremy's going to talk about more specifics in the concept papers that are being released today. So next slide. Again, here's a couple quotes directly from members. I believe you may have seen this before, but I think it's really important that Oregon Health Plan members want investment in healthy communities and in the communities where they live, as opposed to just focusing on our medical system. So these quotes relate to preventive health and really thinking outside of our traditional medical system in promoting health of Oregonians. Next slide. One of the things that we're going to propose on these reinvestments is really looking at broader, issues that affect Oregonians, and not necessarily, and thinking about areas where we'll be better together and not just investing in the CCOs alone. So thinking about broader kinds of programs that could combat health inequities at a community level, and investing dollars in some broad community programs, and also create a voice for communities in determining what those might be. Next slide. So goals of this major policy area are to take the savings that are generated through our global budgets and reinvesting in communities. And again, as I just mentioned, having community leaders partner on the strategies so that there's a voice, and this gets to some of that redistribution of power. Next slide. The successful implementation of a global budget is really what we're focusing on. We know that if we have a cost growth target that's below the national rate of growth, then we will be resulting in huge savings to the federal government. Right now, on average, for a Medicaid member, the federal government contributes about 72 to 74% of the funding, and our general fund and Oregon dollars, fill in the remainder. So our Oregon Health Plan is, substantially paid for by the federal government. So as we generate savings, it's savings to them. And our proposal is that we can share in some of those savings. Next slide. So one of the promising strategies that we have is to invest these savings in what we're calling new health equity zones. So we create health equity zones that would be geographic areas that community-based partners identify, as opposed to just using our current, CCO areas, really looking at health equity zones that are community driven and community identified. And then thinking about the needs within those health equity zones around physical, behavioral health and social health needs that will move health equity forward. So some of the examples of investments that we are envisioning would be culturally responsive healthcare workforce. So as I talked about, really promoting traditional health workers or peer support specialists, outdoor opportunities for members. There's significant evidence that time outdoors and having access to green space has huge mental health benefits, particularly for children. Thinking about affordable, high quality childcare, we know that's an issue in Oregon, and then additional focus on housing and housing related services. Certainly, these are examples of investments, and we haven't, and that some of this will need to be vetted, more thoroughly by community partnerships. Next slide. We will have a piece of, of this investment strategy developed with community partners. And it will be really important to have community partners identify where those investments need to go to reduce health inequities on a broader scale than might happen if we just provided the dollars directly to CCOs. Next slide. So I'm going to actually wait for questions, I think. And Chair Bangsberg, would you like us to wait till the end?
Whatever your preference is, Lori. I think we're doing well on time.
Okay, I guess I'll pause and see if anybody has questions on these two topics, and then we'll turn it over to Jeremy to talk a little bit about concept papers, and we'll dive a little deeper into what's in those concept papers. Anybody have any questions or thoughts before we move on?
Ebony?
Yeah, and I don't know if maybe Jeremy's concept paper might get to it, but I just, in terms of the housing element, I just wanted to find out, I know in the prior waiver that was submitted, there was kind of a plan and strategy around bringing forward some specific strategies around housing. And so I just wanted to know if what we're looking to bring forward draws on that, if that makes sense. And then I just wanted to hear a little bit more detail around the behavioral health piece, but I don't know if Jeremy's concept review is going to cover some of that.
Yeah, Ebony, I don't think Jeremy's will, except that when we talk about the waiver concepts in the concept papers, we'll get a little bit more detailed, but I can answer your question at a high level, I think. In terms of housing, we are looking, it's pretty similar to what was in the last waiver proposal. And I want to be clear that we're not going to be out asking, at least in our equity-centered system of care piece, to build housing. CMS has been pretty steadfast about not investing in the build of housing, that they don't see themselves as a housing organization. However, we will be asking for a suite of housing services, and that's broad. So that can include things like pre-tenancy services, so helping people fill out housing applications, helping people get paid for first and last month's rent, paying for furniture to get started, post-tenancy services to help members keep, and maintain their housing. So those kinds of services, and we'll be looking at a suite of them, is really what we're thinking. But we won't be asking to build, bricks and mortar housing, but to leverage that funding that's coming in the door and through other doorways. In terms of the behavioral health, we'll expand on that a little bit in the next, but our focus, because there's lots of significant dollars, being considered in the legislature right now for behavioral health, we don't want to duplicate that and instead enhance it. And so we're really looking at behavioral health access, and one of the big pieces is in our substance use disorder waiver, we were unsuccessful in kind of navigating an agreement with CMS around peer support. We're hearing over and over it's really important, and so we're going to take another run at promoting peer support specialists, both for substance use disorder and mental health, also traditional health workers, so that we can have a more culturally appropriate workforce and expand the workforce to improve access. So that's the main area, but we'll talk a little bit more about it. Hopefully that answered your question.
Yes, thank you.
John?
Yeah, Lori, in the Invest Savings paper, I think it mentioned trying to get at savings in Medicare Advantage. And just wanted to ask you about that. That's an interesting idea.
Yeah, so we are looking at both savings to Medicaid and savings to Medicare Advantage because it's also a federal program. So it's novel, and I don't know, Jeremy, if you want to expand on it, but that is certainly what we're looking at.
Yeah, I mean, it'll probably be a stretch to get CMS there. They've traditionally only really allowed us to look at savings and require us to hold to budget neutrality within the Medicaid program within our waiver. But there is at least a little bit of precedent. Maryland has a all-payer hospital rate setting model that applies to Medicare. Vermont received a waiver a couple of years ago that included a guaranteed rate of growth that applied to all markets, including Medicare. So there's at least some precedent for trying to bring some Medicare into the waiver conversations. Our pitch is really that as we're moving away from a cost growth target that's only applied to Medicaid to one that's applying statewide to all markets, that the federal government will continue to be a major beneficiary of our efforts, not just to contain costs of Medicaid, but to contain them for Medicare, for federal employees, across the board. So we'll want to see if they can acknowledge that and try to design some type of shared savings arrangement with us.
Well, and I don't know whether they look at the dual eligibles who are in Medicaid, and those savings related to the dual eligibles and disabled, are they already in play in the current waiver, or is that an opportunity?
That's a good question. I actually don't know off the top of my head whether, so our waiver does address dual eligibles, but it doesn't address anything related to eligibility or benefits. It really deals with enrollment and enrolling dual eligible folks and CCOs. And for folks who don't know, dual eligible are folks who are eligible both for Medicare and Medicaid. They receive their primary health benefits through Medicare, and Medicaid provides wraparound services, things that aren't covered by Medicare. And these tend to be very, folks who have pretty complex high health needs. I don't know, Lori, do you know if they, I don't think they consider the Medicare savings in our budget neutrality. I think they only look at savings within Medicaid.
That's right. They only look at savings in Medicaid right now.
Well, it's an interesting stretch. Way to go.
If there are no more questions, I'm going to turn it over to Jeremy.
Lori, let me just ask a question. I really appreciate the emphasis on social determinants of health, because obviously this is the lever that we have to work with to achieve health equity. And if we invest, when we invest in social determinants of health, it's going to take some time to realize those savings because it is upstream. And we could make investments in social determinant health that are well justified in that they reduce disparities, improve health, but may not realize savings. And in the past, when we talk about CCO, we were talking about, at one point, we're talking about a minimum investment in social determinants of health between 1% and 3%. We abandoned that and said, let's see what people do. Is there a mechanism for us to make upfront investments in social determinants of health, before savings are realized? And
That's a good
threshold that we're looking for.
Yeah, no, that's a really good question. And I'm going to start, and then I'll see what other ideas Jeremy has. So you're making a really good point. In general, our investments in social needs are long-term upstream investments. I will say there's work that shows that housing has a pretty immediate return. Some of that work was done in Oregon by Providence Corps, looking at various populations that got housing, and to the point that was brought up earlier, dual eligibles, or people who are qualify for Medicare and Medicaid, we saw huge decreases in hospitalizations and such if they had stable housing. So that's one. The other piece is that the CCOs will be held to a 3.4% rate of growth. That's really where we're looking to see the savings, is that rate of growth in the global budget. So I think that's an important piece. And then there is legislation right now that's being proposed, House Bill 3353, that it does require CCOs to invest, I believe, 3% of their global budget in health-related services or that address social needs. If that passes, then there's the bar. We know in our first 10 years of CCOs that we haven't reached that, and there have been quite a few barriers, to making those investments. We're hoping to reduce those barriers as much as possible, because we do believe, at least for the long-term kind of savings, it's going to be important. If we want to continue to meet the 3.4%, we've got to invest in the upstream for the long term. So
the only thing I would add is, I totally agree with Lori. I think it's multifaceted, both through the cost growth target, trying to get some shared savings with the federal government that we can keep plowing into places that then just continue to generate some savings. The other element, there's a legislation that Lori mentioned, House Bill 3353, that would actually require part of global budgets to be spent on social determinants of health and health equity. The other component of it is the goal, and I'll talk a little bit more about this when I get to global budget on the concept papers, but really trying to change how we build budgets for CCOs in a way that actually creates that incentive to make those early investments, because they'll see the sort of financial reward and savings down the road. Right now they pretty much have to keep adding up all of the widgets of everything they spent, including sort of showing a return on investment. We'd like to be able to stretch budgets out over a longer period of time, and not have them be based so primarily on last year's healthcare spend, in a way that creates more of a financial incentive for them to make those early investments, even if they take a couple of years to generate savings.
Great, thank you. I think I agree with you that the best investment for a short-term turnaround in savings is housing. We're in a bit of a bind that we can't use the money on actual housing, because it is the capacity, it's the housing capacity that's the rate limiting factor. So, but with that constraint, I think I really endorse your thinking on this.
Yeah, thank you. Jeremy, do you want to take the next
Sure.
slide?
Sure. And I would just say, I think it's important I think obviously we want to think about where we can stretch Medicaid dollars to support housing, and how we can bring together funding streams on the ground, where what resources Medicaid can bring, but also couple that with investments come out of the legislature, other investments, and generate more of those conversations on the ground, where folks can figure out what are the various pots of resources that we can bring together. I don't want us to lose sight, though, of how critical cost containment is in healthcare, for trying to solve some other issues as housing. I don't think it's just about the federal dollars that we could get. I think it's also about not having healthcare costs continue to grow at 5 or 6%, because that drains the resources for the legislature bill to invest, and those numbers are enormous. Bending, I think, a percentage point off of our cost growth would probably solve the housing crisis if you could figure out how to capture those savings and reinvest them. So as Lori mentioned, we have 4 concept papers that are going to be released today. I'm going to go to the next slide. These are still fairly high level. They don't get super into the weeds on exactly how we would achieve each of the strategies. We're really trying to lay out, broadly our vision and goals and strategies, make sure that those are directionally correct, continue to work through details internally as well as externally throughout the summer. The purpose of these is really to be able to provide something for stakeholders and partners, OHP members and advocates, and eventually CMS to react to basically tell us, is this the right direction or wrong direction? And if it's the right direction, we can then get to the next level of, okay, how do we get there? But right now at this phase, we're trying to make sure that this is all directionally correct. As I mentioned, they'll be out this summer. We will, over the next couple of months, also start engaging with CMS and starting to get some feedback from them, and they may say some other things in there are just a flat no, and we'll need to incorporate that in and can change direction. But a lot of it will probably hear, okay, we kind of understand what you're trying to do. We have a lot of questions. Come back to us with some more detail. So it'll be iterative as we go through the summer, both with our external partners here in Oregon as well as with CMS. Next slide. What we want to get from you all, and we'll come back for later conversation, but after we walk through these 4 areas, we really at this point want to get, are we on the right track, and are there major gaps, and what needs to be addressed before we get to the point of talking to CMS about where we're trying to head? Are there barriers to equitable health that are not addressed? So that's the general feedback I think we're looking from the board today is, are we on the right track or not? Next slide. Overall timeline, we'll be posting these today and releasing them. They're up on we have a waiver website that's up, which we'll come back to the address later, but these will be just disseminating these out publicly. Throughout the month of June, will be folks can submit feedback a variety of ways. We've got a general email box, but we'll also be continuing to do, we'll do a second round of we call our waiver days. We did a large webinar last week. We had nearly 400 people, I think, signed up to view that. We're going to do another one in June. To get input, we'll be continuing to engage with community partners as well as a variety of standing meetings, including, in addition to the Health Policy Board, the board's Health Equity Committee, the board's Medicaid Advisory Committee, a legislative work group that's been appointed to work with us, the standing meeting that we've got with some CCOs and other organizations. We'll take a variety of feedback, continue to be refining these and putting out more detailed revised drafts that we're aiming for around July 1st right now. And we'll be back to you all in July with a summary of what changes we've made and why. From there, we expect to start to engage with CMS more directly on some of the details, as well as start to move into drafting the actual application. So these, just to give you a sense, the application itself several years ago was nearly 300 pages. There's a ton of stuff that has to go in the application beyond sort of these new ideas. Each time we go in to negotiate with CMS, we have to negotiate the entire waiver, which we've had since 1994. So we have to go back and summarize everything we've done, what the effect of it has been. So there's a lot more that needs to go in the application than sort of these new ideas. So the idea of concept papers is to get are we directionally correct in terms of where we want to go next? And then we'll fold those into the broader application, and we'll go back out for public comment, tribal consultation later this summer and fall. Next slide. This pretty much just shows what I just described, which is now through June, July, getting directionally correct. Second half of the year really focused on the application itself. Next slide. This is the website I was referring to, where we're posting things and where folks can submit input in addition to all of the other forms that that I mentioned, and we'll be scheduling that next waiver workshop soon. Next slide. So I think what we really want to do is bring these 4 topics together and really summarize how they fit together, hopefully. And Lori did this at the outset, but I'll just repeat it again. You know, our overarching story here of the waiver is really advancing health equity, and we've spent a lot of time talking about the triple aim goals of improving quality, improving health, lowering costs generally. That's been a big focus of our national and local health reform efforts the last 10 years. And I think what we've really seen is that we kind of need to take a step up from that and say we've really got to focus on equity first, because despite all of our efforts to improve quality and lower costs, which we've done a good job of, what we have not done is close the gaps on disparities and inequities. So that's our primary goal. The way we see these 4 areas fitting together, you know, first and foremost, getting people access to health insurance coverage. It's very difficult to access the healthcare system if you aren't insured. Medicaid's only a piece of that, but a really important piece of that. So making sure folks who are eligible or uninsured can gain insurance coverage and where appropriate through the Oregon Health Plan, so that then they can access the system when they need help, when they need healthcare access. That the system that they access is really equity centered and provides high quality equity centered care. That we continue to focus on sustainability, especially for the reasons we just talked about around healthcare sucking up resources that are critically needed for other parts of our social systems, and doing that primarily through advancing the global budget to really focus on sustainability and promote sort of wiser investments. And then finally recognizing that there are places we actually need to add resources if we're going to address inequities, and so trying to find some way to capture some shared savings with the federal government, and as we're containing costs, also thinking about where do we actually need to redirect some resources to address inequities. So that's how we see those 4 pieces fitting together. Lori and I are going to tag team the 4 of them when we go to the next slide. Starting with coverage. You know, our vision is that Oregon has the lowest uninsured rate that's possible, with no racial or ethnic inequities in coverage, and that we eliminate those current inequities. Well, the reason we say low as opposed to 0 is I think most experts think 0 is pretty impossible to get to unless you have a system that just automatically, you know, a single payer system that automatically enrolls everybody who's born. Even then, it's pretty hard. I think most countries still have a 1 or 2% uninsured rate for whatever reason. So getting to 0 is probably pretty hard. 97, 98% covered is probably as good as anybody's going to get. Just for context, Massachusetts is at 97%. So if we were to try to beat them, 98 would be a good number. So trying to get to that lowest uninsured rate possible. Our overarching goals is really to stabilize coverage for those who are at risk of becoming uninsured, being more flexible and streamline our eligibility processes so that once folks are eligible and remain eligible, that they remain in, and that we reduce some of the issues of folks falling out even though they are eligible because of just difficulty of managing through eligibility processes. And that once folks are enrolled, that they stay enrolled, and that we don't lose folks as tends to happen each year. Certain portion of folks are just insured and then lose coverage. Next slide. So our pathways on how we get there. First and foremost, we want to ensure that folks who have come into the Oregon Health Plan through the pandemic, that they stay in appropriate coverage. And that may not be the Oregon Health Plan, but it's probably the marketplace if it's not the Oregon Health Plan. So we've had about 200,000 people come on to the Oregon Health Plan through the pandemic, largely because we've stopped doing redeterminations. That's been a national policy to stop doing redeterminations through the pandemic. Our forecasts are that a large portion of those folks will lose coverage once we start doing the redeterminations. But as we're digging into the data, what we're seeing is that there's a very large portion of those folks who have come on during the pandemic, who have been on the Oregon Health Plan at some point in the last year or two. And so what that tells us is that these folks, there's just a lot of folks who are churning in and out, either because their income's slightly fluctuating, or because once they just get the application, it's difficult to manage. They're able to go through it, or they lose coverage until the next time they need it. So we want to first and foremost not have 200,000 people suddenly become uninsured, and to land them in the right program, the place that makes sense, whether that's continuing to be in the Oregon Health Plan or moving over to the marketplace. The second path is ensuring that people who are eligible for the Oregon Health Plan can more easily get enrolled and stay enrolled. The top reason that people become uninsured in the state is losing Oregon Health Plan coverage. And so, as I mentioned, there's a lot of folks, as we look through each month, how many people come on and whether they're on the Oregon Health Plan at some point in the last year. It's a high percentage. And so, a key strategy for trying to reduce the uninsured rate is getting folks who are actually eligible for the Oregon Health Plan today in, and making it easier to stay in. And then third, adjusting eligibility to preserve that continuity. So looking at things like, can we change some of the eligibility processes, so folks are losing coverage because they slightly went above income, that we can build in some ways to factor that in, and try to not have folks constantly in and out, or constantly losing coverage. So those are our three pathways. I see Jessica's got her hand up, so let me pause.
Thank you. So when it comes to adjustment of eligibility, one of the issues that we see this on the workforce side a lot, where you'll have a person who's, let's say, a home health aide or something like this. I actually talked to a woman where this happened. They work a few weeks of overtime, a series of overtime over a couple of months, and it kicks them out of that 138% of income eligibility to, and they get kicked out of the program. When you talk to people as an employer and throughout, the workforce system, we see a lot of folks that are gating their own progress to make sure that they don't mess up their eligibility into this program. And it's really, there's a really big gap, because once you get out of it, you're paying an exorbitant amount in copays, and even if you have an employer that's going to provide coverage to you through a private plan, there's still a huge cost that's associated with participating in that plan. Are there any thoughts on how to better address that issue? Is that even a conversation that's happening at this level right now with the waiver?
Yeah, thanks, Jessica. So that's exactly the conversation that we're having, is trying to figure out how do we smooth that out. So we're still, we've got some ideas in the concept papers, and we're still sort of generating some new ideas. So things we've looked at is potentially looking at longer periods of time that we would look at that income, so there's not quite the fluctuation. Seeing if we could get some flexibility from the federal government to keep people in the marketplace or in Medicaid, depending on where they're likely to be over a longer period of time, so they aren't moving back and forth. The federal government's paying for it one way or another, but every time somebody changes, they have to move health plans, breaks their continuity with their provider. So those are some of the issues that we're definitely looking at.
I would like to see us explore a copay, a small copay from the person who's insured also. So if they pop out of that eligibility bracket, that there's an option for them to also pay in for that care, a percentage or a small percentage to remain eligible. I think it would actually help us out with this situation where we're dealing with a benefit cliff for other programs as well.
Great, thanks.
Can I just highlight briefly, thank you for this, that I think this situation is, I appreciate it being highlighted and solutions being considered for it. And I just want to, we see a lot of people popping between OHP and employer plan who aren't eligible for the exchange because the employer offers a plan, even if it's, you know, as Jessica pointed out, people still can't afford it. And so I want to make sure that when you're thinking about those solutions, Jeremy, that like people aren't exclusively popping between the marketplace and OHP.
Yeah, thanks, Kristen. And I you know, there's, to kind of complicate things a bit, there's a set of strategies that that we could put into the Medicaid waiver, potentially our application. There's a set of strategies that might be related, but not actually directly on our Medicaid waiver. That might be, there's a separate waiver process for the marketplace. So all of that, we would like to be able to sit down and talk through a CMS, and it may be that, you know, it's two different waivers or different applications, but overall, you know, if we're on a course, which we have been for a long time in Oregon, to get to universal coverage, and we're sort of starting from that as our premise, how do we just make it easier for folks to be in and to have that continuity? Other questions before we move on?
I'll save my questions for the end, Jeremy. Thanks.
Okay. Laura, I'll turn it over to you for the next one.
Great. Next slide, please. So I'm back to creating an equity-centered system of health. I'm not going to necessarily go through this because I already did on terms of the goals, but just to remind you, kind of in shorthand, you know, we want to establish an equity-centered system of health so that all Oregonians can achieve their optimal health. And that's going to involve enhancing care coordination, removing barriers to access, particularly around behavioral health, and then prioritize groups of people who are currently experiencing inequities in our Medicaid program, and you know, focusing on achieving an equity centered system of health. Next slide. So earlier I told you I was going to come up with list some pathways in my first set of slides, and so here they are. So when we were talking about, you know, the four different areas, when in my first set of slides about creating an equity-centered system of health, you'll remember we were talking about transitions, improving the behavioral health access, creating, you know, a package or a suite of services, and then addressing tribal needs. So here I'm going to talk a little, give you a little bit more detail around the specific pathways to get there. So the first is this, you know, identify these destabling transitions that I talked about, and asking the federal government that we can have for coverage during parts of those transitions. So the kinds of things that we're thinking about, you know, the transitions are transitioning in and out of the correction system. So that could be jails, that can be prison, that also would be youth facilities like as well. So we're identifying youth. We've talked about coverage during pre-adjudication. So before a person's been convicted of a crime, so that there can be a warm handoff from their current Medicaid health plan to the correctional institution, so that you know, someone understood the medical system in the correction facility understands their meds and prior conditions. And then we will be asking for coverage 30 days prior to release. That would be a limited benefit. So really allowing care coordination services during that time, an ability to access some of these coordinated transition support packages or that meet social needs, so that someone can walk out of prison or jail with 30 days of meds, already have a primary care or doctor's visits that they need, already have their Medicaid coverage, and have social needs met. So that would be a more specific example. The other kinds of transitions that we're looking at are acute care hospital stays for people who are suffering housing insecurity or are homeless. transitioning in and out of psychiatric treatment facilities, and this would include youth as well. Youth that are coming in and out of foster care. Also, those who are aging out of foster care have specific needs. We're looking at transitioning into a longer postpartum period after birth. We know nearly half of babies born in Oregon are on the Oregon Health Plan, and that's providing longer postpartum services for the moms of those babies. And then prevention of an imminent mental health crisis. So looking at a transition, in and out of a mental health or behavioral health crisis. The second step, once we've identified these transitions, is to create support packages or suites of services that can be offered to people who are experiencing these destabilizing transitions. And so some of those might include care coordination services, some of the intensive care coordination that I talked about earlier, health-related social needs. So like I was talking about, housing suite of services that would help with pre-tenancy, getting into a house, and then maintaining that tenancy. Also system navigation, so childcare, housing, finding housing, and then some support for recommended medical services that we don't currently cover, and recommended access to providers like peer support specialists. Then the third step is to improve our behavioral health system to better support members. And this is, again, particularly at these times of transition. So one is to, I've talked about it a number of times, but build the capacity for traditional health workers and peer support specialists. Also, expanding the behavioral health benefit for kids to make sure that they receive, a robust kind of suite of behavioral health services, and extending that up to age 25. And then expanding opportunities to upgrade our behavioral health crisis system and increase community health workers and peer support specialists for people during crisis. And then step 4 is to ensure that these providers and partners like traditional health workers or peer support specialists that are working in non-clinical settings, so they're out in the community, have training and support to participate as a care partner, and don't necessarily have to have direct clinical oversight, but still can get paid. And then finally, looking at improved screening processes so that we can find people who are engaged in multiple systems of care and really look at how to better coordinate care across these systems. Next slide.
All right, I just looked at the clock and realized we're way short on time. So, let me just summarize real quickly the last two, so we can get to discussions. The next area is around encouraging more smart, flexible spending. The idea here is really to advance the global budget concept, move away from primarily setting rates based off of last year's spend, and look at a budget that's built over a longer history and lasts for a longer period of time. The idea being if you can actually create the financial incentive for CCOs to make upstream investments that both reduces inequities, promotes health, and lowers the downstream costs, as you all know. We also included a proposal in there around really revamping the quality pool program, which has been a core element of our transformation to be really grounded in equity, and moving towards creating 2 sets of metrics, one that are really aligned with other things we have to measure for CMS, kind of traditional quality access standards, and but then have a core set that's really more upstream and focused on really pushing on equity. Next slide. Next one. And I don't think we'll probably need to say a whole lot more about shared savings. We covered this earlier, but our idea really is to build off the effort to move to a statewide cost growth target, recognize the federal government's the primary beneficiary, and that there are places where we recognize we do need to actually add some dollars, at least on the front end, to address inequities within the system. Next slide. So next slide. I think for now, just throw it open for questions or comments. And like I said, I think we're primarily looking to understand, are we right track or we're on track?
Lori and Jeremy, thank you so much for this. I am just astonished about the level of preparation that you all have given this for, both in the webinars that have preceded today's call, the level of materials that you've provided for us. I just feel super prepared. So thank you for that. My question is about less about specific elements of it and the concept papers as they're currently drafted, but mostly around the process of inclusion and stakeholder feedback. When we've talked about this topic in the past, I think, heard from you, rightfully so, about how important it is to consider this isn't the one size fits all kind of a window of opportunity, and that we don't get our heads wrapped around the idea that every transformational effort gets somehow nested in the 1115 waiver and kind of open and close and then we're done kind of thing. So, and at the same time, I'm recognizing how many people just might be super interested in weighing in and providing helpful information. We've talked about using our Medicaid Advisory Committee, right, as the placeholder, the spot where we're going to be processing community engagement and feedback. And it looks like there's a pretty, like a month or so where these concept papers become the mechanism for those very conversations. So if I understood all that correctly, my question is about how exactly we can set guidance for the committee to deliberate areas of feedback that we think are really actionable and reframe the concept papers or add to it, things that fundamentally shift your thinking from what you've already drafted, and how the committee feels the right level of guidance from the board in order to do so.
Thanks, Brett. I can start, and Lori, feel free to jump in. We've been working through what the right role is, both for the Medicaid Advisory Committee as the Equity Committee. I think I've made a lot of progress. The Health Equity Committee is primarily going to be focused on making sure that what we've drafted here, as we've talked about before, given the timeline that we're under, and the fact that we've gotten some flexibility to apply it by the end of the year, but beyond that, we're kind of stuck with a timeline that's faster than I think any of us had hoped for. We were expecting we were going to be talking about waiver last March, April, before the pandemic, and so things are crunched. So we've really had to start from a place of what have we already heard in the past from community, and so we've asked Dr. Bainsberger has asked the Health Equity Committee to really make sure that what we're reflecting does in fact reflect feedback we received in the past, and that overall it does really move the needle on health equity, and to be providing that guidance to the board. Similarly for the Medicaid Advisory Committee, really looking to make sure that from a member perspective, this really does address some issues that they hear about from members, and have been talking about each of these topics with them, and planning to go back again in June and July. I think I had a conversation with them on Thursday, and I think one of the things that the Medicaid Advisory Committee brings that's really, really important is actually the specific member story. It's one thing to talk about the policy and to talk about a change of rule, but what I heard from them last week was a lot of really specific examples of challenges people have trying to navigate the system, and how a policy can improve that. So I think, overall, this is going to be pretty iterative over the summer. It's not like we can have one conversation and wait to do any work until we've had a whole bunch of conversations. So we're gonna have to kind of weave together feedback from these different groups that meet at different times. Lori, anything to add?
Nope, I think you covered it well, Jeremy.
I think Ebony has her hand raised.
Oh, thank you. Yeah, so mine's, I guess I just have a couple of comments where, I always like to toggle between kind of short term and long term. And I just, also think it's going to be important, to make sure that we're bringing forward and thinking about strategies for sustained funding in the long term, and looking again at the interconnectedness between, you know, being able to leverage, you know, general funds to work and support our Medicaid efforts. And so I just think that that piece is very important. And, you know, I think there's also this balance between, you know, I love and appreciate the focus on peers because it's much needed. And I feel like that is a missing link in terms of being able to see some of our efforts, specifically around behavioral health, be, you know, achieved. However, I also think about the crisis we're in terms of the workforce shortage when it comes to behavioral health providers. And, you know, and as we think about all these efforts around expanding access or capacity, it's contingent on having a workforce to be able to provide those services. And so, you know, that's just where my mind is at, and a lot of opportunities. And I just look forward to, you know, doing my part to, you know, meet the need and achieve our gain and our outcomes. So thanks.
Yeah, thanks, Ebony. And I don't know if you can see us, so I want to make sure you see that we're nodding our heads yes in agreement, and agree that the waiver is not going to be able to solve all of our things. This, you know, needs to be coupled together with investments come out of the legislature and other things, and totally agree that if there isn't a workforce, then it doesn't really matter if people have insurance if they can't actually access the system. So that's obviously critical.
Other comments or questions? Oh, John, go ahead. Yeah.
Hey, I think it's terrific stuff. Thanks for sharing it. Thanks for making it public. It's terrific.
Great, thanks, John. And the concept papers will be posted here shortly, so everyone can go read them.
Kirsten?
I agree. This is great. It's interesting to see a lot, or I see themes with the ship reflected in it, which I think is great and appropriate, especially around the kind of economic drivers of health. I was curious what role, if any, the regional health equity committees play in voicing and giving feedback on this.
I can answer that. So we have been meeting recently with the regional health equity coalitions. They sponsored or had a hand in developing the House Bill 3353, and we've been in conversations around how to amplify, you know, that message and those policies in the bill in the work that we're doing. So we're having direct meetings with the regional health equity coalitions on those topics. Jeremy, you want to add anything?
Well, I think that this is a great introduction to a topic we'll be talking about over the next several months. Jeremy, Lori, thank you so much for this introduction to more specific work that the waiver will pursue. Also really appreciate the legislative update and the cost growth target update. You know, OHA staff have done a fabulous job bringing us along as a board with the webinars, with these meetings. I really also appreciate the public comment we had today. Thank you for contributing to that. I think that was very constructive given the discussion, especially given the discussion day. And a giant thanks to my fellow board members for a generative, thoughtful, constructive discussion. I really learned a lot by listening to how y'all think, and I think we do a much better job together than any of us would do individually. So thank you, everyone, and we will look forward to seeing you again next month, if not during a webinar or some meeting in between. Have a good 4th of July, and we will see you on July 6th. Very good. Bye-bye.